Welcome to the 11th Annual 2020 Mom Emerging Considerations in Maternal Mental Health Forum. Together, Joy Burkhardt and I, with the support of our sponsors and team, have curated an incredible program aimed at closing the gaps in maternal mental health. Let us welcome to the stage Joy Burkhardt, our founder and executive director, a mother, a visionary who started it all. She has transformed a vision to a movement that is now 2020 Mom.
Well, I too would like to welcome all of you. As you know, up to 1 in 5 women will suffer from a maternal mental health disorder. Yet even in the year 2020, most aren't being screened, diagnosed, and treated. If you are here, it's because, just like the two of us, you are a change agent. You are motivated to ensure all women are screened and those suffering are diagnosed and treated. You are motivated to see women and families supported in practical and emotional ways to prevent and ease the burden of maternal mental health disorders. Together, over the next few days, we're going to explore the latest research, the latest policy, and systems change opportunities together that have the possibility to make this vision a reality. Over the next 2 days, we have 50 speakers, 6 breakouts, 10 exhibitors, and most importantly, space for all of you to connect and formulate your next step in effectuating change. We're so glad that you're here and a part of the 2020 Mom family. This event is made possible by our sponsors, including our presenting sponsor and close partner, who's invested quite a bit in maternal mental health here in California and beyond. And we want to thank the California Healthcare Foundation. Stephanie, thank you. We also want to thank our platinum sponsors, the Zoma Foundation. Rebecca, thank you. Sage Therapeutics, our team. Marjorie is outside. Oh, back here. Thank you, Marjorie. And Cigna, who is represented by several people in the room as well. We also want to thank our gold sponsor and our Mom Tech lunch partner, Hope Lab. Hope Lab, are you in the room? Not yet. Oh, yes. Very good. Thank you, Hope Lab. And our supporter level sponsors, Mommy and the Hannah Institute and Maven. If you could all raise your hands as well. Thank you so much for investing in us. We're so very grateful for your support in making this event possible and for the services that each of your organizations are providing to providers, women, and families. You can learn more about these sponsors in the conference app. There's instructions on how to download the app on the table. All right, I'd now like to invite 2 special people to the stage. Ed Paget, one of 2020 Mom's ambassadors. Ed, please come on up. And Brooke Tomlin, the Director of Health Equity and Social Determinants of Health from Cigna. Come on up to the stage. And I want to share that Cigna is a very special company. It's where I have worked for nearly 25 years, and I'm tearing up. I didn't expect that to happen. I still have the pleasure of working for Cigna now just on a part-time basis, thank goodness, so I have more time to invest in 2020 Mom. But Cigna was the first and only sponsor of our very first forum 9 years ago and has continued to sponsor and invest in this work over the years. So Cigna, thank you so much for believing in me and also believing in 2020 Mom. For the last 4 years, Cigna has also sponsorship has allowed us to provide scholarships to several of you in the room and even some webcast sites by investing in the Charlene and Shane Memorial Fund. And we're so grateful for that support. Brooke?
Thank you, Joy. As a global health services company, we're committed at Cigna to addressing whole person health, both body and mind. We're expanding our mindset and actions to consider how behavioral conditions and social determinants of health including stress and loneliness, can impact one's total well-being. You'll hear more on this important subject today from Dr. Stuart Lustig, our National Medical Director for Behavioral Health. Cigna's proud to have been an original investor in 2020 Mom Forum and a sponsor once again this year. As Joy mentioned, a portion of our sponsorship will help fund the Charlene and Shane Ventanilla Memorial Scholarship Fund, which enables advocates working for nonprofits, doulas, and lactation consultants to attend this year's forum. To share with you more about the fund, I'd like to introduce dedicated advocate for maternal mental health, Ed Puget.
On behalf of my wife and myself, thank you for allowing me to be here today to honor Charlene and Shane, who we lost 3.5 years ago to postpartum psychosis. As a dad and a grandfather, it meant a lot that they are not being forgotten. Charlene would have turned 40 this month. Unfortunately, this type of education is not found in a book. Attending a forum like this will help everyone. I know most of you know the story, so therefore I'm not going to repeat it, but we would like to say thank you to Cigna for the scholarships and the congratulations to those recipients. Additionally, I'd like to thank 2020 Mom, and most of all Joy, for having the vision, the foresight, and the will to make this forum happen.
Thank you, Brooke and Ed. Before we introduce our first speakers of the day, I want to pause and ask you to join me in reflecting that the fact that this year is 2020. And we are 2020 Mom. It seems like yesterday when 2020 Mom shared our bold goal of closing gaps in maternal mental health by year 2020. Back then, the goal seemed daunting, but now we have arrived. People often ask me, what will happen in 2020? Let me first tell you where we have been. AB 159, the first maternal mental health task force bill, was introduced by the Junior League, where Joy Burkhardt, our executive director, was volunteering at that time. The bill didn't pass as it relied on state to fund the task force, and it was the height of the budget crisis. In 2010, with the Junior League's leadership, California declared May as a Maternal Mental Health Awareness Month, and in that resolution, the Senate urged volunteers to form a task force. So Joy convened the first stakeholder meeting, and that group became the California Maternal Mental Health Collaborative. In 2011, the collaborative became a nonprofit. In 2012, the collaborative launched the 2020 Mom Project, which set forth an aggressive path to solving maternal mental health crisis by year 2020. The project identified key roles insurers and hospitals could play in scaling change. In 2014, Zoma Foundation, previously the Ben and Lucy Anna Walton Foundation, gave 2020 Mom our first foundation grant to create the Community Action Toolkit to close the gaps in communities. Also in 2014, 2020 Mom founded the National Coalition for Maternal Mental Health, an alliance of nonprofit organizations that hosted Maternal Mental Health Awareness Week and social media awareness campaign, and sponsored the Bringing Postpartum Depression Out of the Shadows Act. In 2015, the California Task Force on Maternal Mental Health, a Blue Ribbon Commission, was formed due to the passing of ACR 105. Also, in that year, we changed our name to 2020 Mom from the California Maternal Mental Health Collaborative. In 2016, through the National Coalition, the U.S. law Bringing Postpartum Depression Out of the Shadows Act was passed and signed into law by President Obama as part of the 21st Century Cures Act. This law provided grants to 7 states thus far to improve telepsychiatry access. In 2017, the California Task Force in Maternal Mental Health unveiled its report, also known as the State Strategic Plan. The recommendations in that paper address critical gaps that affect all states, not just California, many of which we will talk about today and tomorrow. In 2018, that paper also led to the introduction of a comprehensive maternal mental health bill package in the California legislation, 2020 mom-sponsored. Notably, AB 2193, Maternal Mental Health Screening and Insurer Support Bill, and AB 3032, Hospital Maternal Mental Health Bill. In 2019, after holding 3 independent Hill Days on Capitol Hill in DC, 2020 Mom invited nonprofit partners addressing maternal health and paid leave, and launched Mom Congress, which has now become not just a mom moment, but a movement. In December 2020, after the year of 2020 Mom advocating through the Congress appropriations process, the President signed his budget bill, which included funding a federal maternal mental health interagency task force. The Health and Human Services Agency is tasked to convene a task force of various federal agencies, including Office of Women's Health, the Surgeon General, the Health Resources and Services Administration, Maternal Child Health Bureau, and Substance Abuse and Mental Health Services Administration. Although much has been accomplished, there's still so much to do. We can do more. In 2020, we are narrowing more gaps in maternal mental health because together, we can do more. Also, we can do more by learning, making our voices heard, sharing ideas, connecting with people, and sharing our stories. We have created spaces for interaction and engagement so you can leave here feeling inspired and charged. We encourage you to share our ideas and thoughts by answering the question on the easel boards around this room and in the hallway. On your right is Monica, our graphic facilitator, where she will transform our discussions into graphics. So now let's get this program started. I hope you enjoy what we have in store for you. Stories are impactful ways to create change. Stephen D'Achille, our first speaker, is here with us today to share his story. He is the founder and the president of Alexis Joy D'Achille Foundation for Postpartum Depression. Stephen created the foundation with the help of his family in the wake of the passing of his wife, Alexis, to increase awareness concerning women's perinatal mental health issues and improve treatment options for women and their families in the Pittsburgh area. Stephen is a loving father. His daughter, Adriana, is the shining beacon of his life and his devotion to her, his guiding principle. Let us welcome Stephen.
Good morning. On August 30th, 2013, my wife Alexis and I had our first child. On October 8th, my wife lost her battle with postpartum psychosis. However, she did not pass until October 10th. After 41 long weeks of a seemingly perfect pregnancy, we were left traumatized from a not-so-perfect traumatic birth. Adriana's birth was a code blue delivery, meaning her life was in jeopardy. With this type of delivery, doctors rush whoever's life is at risk. In this case, it was Adriana's. There was no doctor in the room for our daughter's delivery, just myself holding one leg and a nurse holding my wife's other leg. Adriana's umbilical cord was wrapped multiple times around her neck, and she didn't have any slack to come out. This birth scene was far worse than any nightmare I could have ever imagined. I can only think what it must have been like from my wife's perspective. I feel neither her or I were prepared for a good birth experience, let alone a traumatic one. Alexis was not a typical mother in that she suffered in silence. She knew she was in trouble and desperately sought help. She was very blunt and upfront with everyone that would listen. Her battle started in the delivery room. 12 minutes before my daughter was born, there was a doctor in our room, a doctor that both Alexis and I had known throughout her 41-week pregnancy. However, since it was our first child, the doctor shrugged off her insistence on pushing because she couldn't hold Adriana in anymore. The doctor rather matter-of-factly said, "This is your first child. You can waste your energy pushing now, or you can save it for 2 hours from now when the baby comes." She had a multiple birth delivery in the room next door and a high-risk birth after that, and said she'd be in when those 2 births were completed. 12 minutes later, Adriana was here. This was the beginning of the end for my wife and I as we knew it, not just because we were now a family of 3, because we were faced with the challenges of perinatal mental health issues, which we knew nothing about. Adriana was a beautiful baby, but all she did was cry. My wife, imagine as a first-time parent, really believed in her mind that her first act of motherhood was damaging her child. And this led to neurological testing on our daughter, all of which came back good, but it was a response that she refused to accept. She really believed she had given our daughter brain damage. It was obvious to everyone around us that Alexis was struggling. Her mother stayed with us for the first 2.5 weeks. It was a huge help. When she went back to Jersey, her mother, things really took a turn for the worse. About 2.5 weeks after Adriana's birth, we had our first doctor's appointment with LCSW at the same hospital where we delivered Adriana. This LCSW was part of the OBGYN team that we chose at the beginning of our pregnancy. This appointment was in the evening at a hospital where Adriana was born. The LCSW was a sweet woman who seemed to be very concerned with Alexis's mental state. It was here where we learned that Alexis was diagnosed with PTSD from the delivery. This appointment was brought about because of Alexis's debilitating anxiety. Throughout the pregnancy, we heard about the baby blues, and we even heard about postpartum depression after. What we had never heard about was postpartum anxiety. After this appointment, we left with coping exercises to help deal with anxiety and panic attacks. Most mornings started out with phone calls to a local crisis center, all of which involved a mobile crisis unit coming to our home. This was a huge worry for Alexis because it was, what are the neighbors going to say? Everyone's going to think I'm crazy. Everyone's going to know I'm a bad mother. So for this reason, the crisis teams, the mobile ones, were always turned down. Lack of sleep, nutrition, breastfeeding issues, the perception that she damaged our daughter during delivery all led to her rapid decline. Over the last 13 days of Alexis' life, we went to 7 different hospitals or crisis centers. Each and every one of them had no idea what to do with a woman suffering from postpartum depression. They had no knowledge at all about postpartum depression. It was, abundantly clear that all the psych doctors didn't want to deal with her. They blamed it on the baby, and they said it was an OB issue, and they recommended she go see her OBGYN. All the OBGYNs said, no, this is a psych issue. You need to see a psychiatrist. Because there's such a shortage of psych doctors in this country, every woman, my wife is no different, is forced to see the OBGYN. And this led to her OBGYN prescribing antidepressants to her that I believe she should not have been prescribed. I contribute the antidepressant to her escalating her PTSD, PPD, and PPA into postpartum psychosis. She had never had a suicidal thought until she was put on antidepressants. Rather than adjust her medication at her second appointment with her OBGYN, her doctor doubled her dose of her antidepressant when she had made it abundantly clear that she was having suicidal thoughts on the regular dosage. As a husband, I didn't know how to help her other than to support what the doctors were saying. I wish I had told her to get off the antidepressants like she wanted to. On October 3rd, it was our 4th wedding anniversary. I took her to a psych unit in the city, and we were in a double-sided glass room that locked from the outside. And she was talking to the doctor, she was begging to be admitted, and the doctor kept telling her, "You're not crazy, you're not like them. When you get behind that wall, it's a different world, you're not like them." And we were there for hours, and she was talking to a social worker, I was talking to the doctor, and at the end of the appointment, I pulled the doctor aside and I said, "Doc, I'm scared, I don't know what to do. How do I protect my wife?" And he said, "Pretty girls like her would never take their life in a sloppy way. She would never want anybody to remember her not looking her best. There's only 2 ways women like her take their life. One is asphyxiating themselves in the garage using their vehicle. The other is overdosing on pills." So I was instructed to get car keys out of the house and to take any pills out of our house. And she hung herself. And I guess for me, I didn't really understand this disease or how much trouble she was in until one day we were driving to my grandmother's for dinner, and she looked at me in the car and she said, "Why don't we give Adriana up for adoption?" And it was and this made perfect sense to her, and she just wanted to go back to our old life, the perfect life we had before we had a child. Being separated from Adriana was, I would think, the biggest barrier to care for my wife that prevented us from getting the help we needed. I believe there should be safe places for all moms to get the care they deserve with their babies next to them and the support of their partners. One morning, we were the first people at a local crisis center where we live, and we had pulled up in a older Mercedes-Benz, and when we pulled in, the lady at the front said, you pulled up here in a Mercedes and you think you have problems?" We were there at 8 a.m. At 4 p.m., the psychiatrists, 3 were on duty. They saw every patient that went through for the day except for us. We waited all day long. And they told us to come back on Monday. We'd have better luck because they'd have 4 psychiatrists on. And on Monday, she was dead. I believe that women, I think it takes a lot of courage for women to admit they're having these feelings and to speak up and tell doctors and loved ones that you're having these thoughts while holding your infant. It's not an easy thing to do. And for the women that are brave enough and smart enough to seek help, to always get the same answer, go home, be with your friends and family, you'll be fine. It's no wonder that suicide's the leading cause of death in women while pregnant or the first year after delivering a child. And it's just not fair. So I truly believe that helping moms is helping families. Thank you.
Our next speaker is Dr. Pil-Young Kim. She is an associate professor in the Department of Psychology and the director of Family and Child Neuroscience at the University of Denver. She received a PhD in developmental psychology from Cornell University and received a postdoctoral training in developmental affective social neuroscience at the National Institute of Mental Health. Dr. Kim researches the structural and functional plasticity in mothers' brains, and such plasticity supports parents' psychological adaptation to parenting and sensitive caregiving for infants. She has over 50 publications and was awarded the Victoria S. Levin Award for Early Career Success in Young Children's Mental Health from the Society of Research in Child Development. Please welcome Dr. Pil-Young Kim.
Okay, so thank you so much, and Joy and Apple, to invite me to be here. I'm really honored to be in the same room with you and have important discussion to help the mothers during pregnancy and the early postpartum period. I share very similar ideas that I do think that every parent, from whichever the background, have a right to parent their children in a safe and supportive environment. So I see my role as a researcher to provide scientific evidence that can be helpful for the important works that some of you doing in the clinics and in the field. So yes. And my first name is a little hard to pronounce. It's Pil Young. It's a Korean name. So I tell people it's like a singer named Neil Young, but it starts with P. But I have to come up with new it because I realize younger generation don't know who Neil Young is. I was like, oh, where's that person? Okay, so the overview is sharing some of the research that I did and some other people did, showing that the human mother's brain change after they have baby. And then because it's a period with a lot of brain plasticity, the brain develops during this period of time to actively support parenting. It is also time the brain can be receptive to environmental influences that can be both negative and positive. So I'm going to share some evidence that especially if the mothers are experiencing really high levels of stress, how that can be related to some different changes in the brain that can result in some negative outcomes that we care about. And then last, I'll do some brief discussion about how this is the window of vulnerabilities and opportunities so that we can transition to panel discussion. All right, so I think that this is the audience that I don't think that I have to say much about, but I think I think the public thinks that the parenting is, natural and it's instinct, it's beautiful, but I think people who have had children before or have seen people who had children know that it is really demanding and stressful experience. So just the example here, the newborns is fed 8 to 12 times every 2 to 3 hours. So this mom is actually documenting that she fed her child 3 a.m. and 5 a.m. and 9 a.m. It's like a 24-hour cycle, right? And the left-right is basically which side of the breast that she used to breastfeed, because we're so sleep-deprived, we can't remember, right? When this is true, that the parenting does have this side that, it is very stressful, it requires a lot of sacrifice from the parents, both psychologically and material, from point of view. And then, for the scientists like me, I have to wonder then why we parent our children. Why do we have a child, right? Because for the first time, we can say that, well, I didn't know how hard it was. But I have 2 kids, so the second time, did I forget everything? So, for humans like us, we don't like to do things that's really hard. But it's really interesting that, for the generations and generations that we're willing to sign up for this really hard, life-changing experience, there has to be some mechanisms in us to motivate us to do this and support us to do this. So that is the question that I ask a lot in my research. So what is it that motivates us to have 1 child, 2 children, and willing to sign up to care for that child for 20 years or 30 years or 40 years, and if you're lucky, right? So, we think that one of the really important factors is that that emotional bond we make with our children is very rewarding. So these are the pictures of my 2 sons. But that smile, that eye contact that they have with me, the sweet smell the soft tactile when I hug them. I mean, just thinking about it makes me, like, my heart just swells. It's that kind of like a feeling that I cannot really describe. It's just a really different kind of positive feelings that we have. And indeed, brain actually helps us to feel that way. So, brain has this number of the connections in the brain areas that we call the reward circuitry. So these brain areas respond to anything that makes us feel really good. So that could include food, drug, sex. But when we have baby, these brain areas are particularly sensitive to babies, especially our own babies. And that helps to bring this positive, really content feeling, and also makes us feel like, I want more. So, that helps us to, not only to feel motivated to take care of our children, but wants to have 1 child and 2 children and 3 children if we can, right? And indeed, that, so this is the part that I just talked about, that, the mothers have this increased kind of reward sensitivity to the baby because of that brain circuitry. And we share very similar brain circuitry with all the other mammals, actually, because, we are in a way that programmed to do this, evolutionary. So other mammals also have a very similar, this reward circuitry that's very important for parenting. And like I said, this brain area also responds to other very rewarding things. So for example, rodents like rats and mice, the females, they don't show any maternal instinct before they have baby. But once they have their own pups, they become actually a very dedicated mother. So what happens is that before they have their own pups, they also like cocaine, just like, human. So they like to get as much as of that, if they could. But what's really interesting is that once they have their own pups, that preference switches. So even though they have option to access cocaine, they actually prefer to spend more time with their babies because their reward circuitry more strongly responds to their own babies. It brings them more joy and the pleasure. So this chart basically highlighting that. Early postpartum period, which is the period that when pups need the mothers the most, you see that in this gray bar that the mothers spend more time with pups than access cocaine. But the late postpartum period, by the time when the pups are more independent, mother's preference switches. So as you can see in the black bar, that this rat mothers spend more time getting cocaine rather than spending time with their pups. But having the motivation is one aspect. The other aspect is that we need to be able to manage the stress that comes with parenting. So that is what we see in the mothers during late pregnancy or early postpartum period. It seems like there's biological mechanisms help us to have more kind of like reduced stress response. So the typical mothers may show that like they don't seem to be stressed out about by the things that they would normally be stressed out about, so that we can be a better mother to focus on the role of parenting. And we see that also in the brain mechanisms that, that mothers show like greater prefrontal cortex activations when they're listening to baby cry, for example. And when we do the surveys with mothers and also the fathers, actually the blue bar is the fathers, what we see here is because of this support from the brain and other hormonal mechanisms that, while it's really normal to have some increased anxiety right after they have the baby, so for example, like 2 to 4 weeks postpartum, that kind of normal increased level of anxiety will subside a little bit by the 3 to 4 months postpartum. Of course, we're very concerned if the mothers have really sustained high levels of anxiety or depression during this period of time, but typically that these levels will go down, and what happens is that over time, the mothers start feeling more positive about their own baby and also about the parenting, which is really the critical mechanism for us to feel like rewarded in the parenting role. And we may be also concerned if there are parents who don't have this type of a transition, that they remain very anxious or depressed during this period of time, which may be related to the fact that they have really hard time to feel positive about their own baby or the parenting itself. And like I said, for the reward part, the motivation part is really strongly involved in the middle brain regions like substantial nigra, ventral striatum, or nucleus accumbens, and amygdala. And emotion regulation also involved many different brain regions, but if I highlight, that would be prefrontal cortex. So we see increased prefrontal cortex activations when we present baby stimuli in the scanner, for example. So many years ago, we were really interested in that, non-human animal work showing that there's brain structural changes after the parents have baby to support the psychological processes, feel more motivated to care for children and have more increased emotion regulation. But we weren't really sure whether that could be true for human mothers. So when we actually invited the mothers to come twice to the fMRI scanner and took the picture of their brain at first months postpartum and again 3 to 4 months postpartum, what we saw was that structural increase during that first few months postpartum period in the brain regions that's highlighted in red. So it's quite a number of brain regions that show structural increase during this period of time, and they're really critically involved for parenting, detecting the baby cues and learning and decision making, emotion regulation, and so on. So not all changes negative in the brain. Like, we talked about mommy brain, and I definitely experienced that, but perhaps not everything is negative during this period of time. And importantly, we saw that structural increase in the reward area highlighted in the circle, the yellow circle, was also positively associated with the mother's feelings about their baby. So the greater structural increase in the reward area was related to more positive perception about the baby. So the way that we measured it was that we present a number of the positive and negative words and see how many of the positive words that the mothers choose to describe her baby. So the more words that she used, like adorable and beautiful, were associated with the increased brain structure in the reward area. So this was, a kind of part of the evidence that how we feel as a mother and the changes in the brain might be related. And we replicated this finding in more kind of socioeconomically and ethnically and racially more diverse sample. So the later postpartum months were also associated with the greater cortical thickness in the prefrontal cortex, in the color regions here, and even also stronger functional connectivity, meaning that different brain regions actually communicate a lot stronger. We found that in the later postpartum period. So these all supports that the mother's brain goes through really dynamic changes after they have baby, which is not very surprising actually to me that how intensive the parenting experience is. So, if we talk about learning, this is really intensive learning experience, right? And of course, the brain changes to support and reflect that experience. I should mention, though, that this is not my work, but others also have found that during pregnancy, the brain also shows structural decrease. And it seems that the mother's brain overall during this period of time will go, experience wax and wane. So during pregnancy, the idea is that when some of the brain regions here highlight here, so this is pregnant woman, and this is control woman. So as you can see here, the structural decrease there seems to be related with the higher estrogen level during pregnancy, which then relates to some pruning in the brain area, meaning that the brain actually kind of get rid of some of the connections between the neurons in the brain area they don't need. So in a way, they're kind of preparing the mother's brain to communicate more effectively. So again, highlighting that the mother's brain goes through really dynamic changes during this period of time, which it can be considered quite unusual for the adult brain, that we consider adult brain's structure and function might not change as drastically, but it seems like the pregnancy and postpartum period are exception. Because of these findings, a number of the people consider the perinatal period, like pregnancy and postpartum period, might be really the window of vulnerabilities and opportunities. The fact that the women are particularly vulnerable to prenatal and postnatal psychopathology during this period of time might be related to some of these brain changes, but also maybe a window of opportunities that the brain also receptive to positive experience or intervention and support. But first, to focus on some evidence that we see the mothers, the postpartum period is really hard period for any mother. Like when I had my first kid, I already knew something about parenting because I was already studying the topic. But, so I thought like I was really prepared. And my mom was like, you don't know anything. And when I actually had my first child, like I was so surprised. Like I remember, crying really hard in the bathroom. Like I didn't know how hard it was. And so it's really hard experience for any woman. But we know, I think from some of the examples or our personal experiences, some mothers are particularly vulnerable during this period of time. And one group of mothers maybe is that the mothers who are already experiencing really high level of stress, and then they have to manage parenting on the top of all those burden and stress. And then that environment, one of those environments can be represented by poverty. So I thought it would be important to study mothers who are experiencing poverty and how that really high level of stress can perhaps disrupt these normative changes in the mother's brain. So for poverty, I think many of you already know, so I might not have to mention this, but in research, the way that we define is based on their family income. So for example, the federal government has annually adjusted poverty line. So for Colorado, 2019, for the parents, the family of 4, 2 adults and 2 children, the poverty line was around $25,000, that's annual income. So if the family's total annual income is below this line and their income to needs ratio is below 1, and by definition, they're living in poverty. And low income will include these families as well as the families, their income to needs ratio is below 2, so maybe about 50,000. And we call them all as a low income families because that is still not enough income for them to meet the basic needs. So in US, about 40% of all families are living in low income, which is really kind of high percentage. And then when you hear also socioeconomic status, that can be represented by income or education or occupation, any combination of those. And the mothers who are living in poverty, not too surprisingly, on average, experience high levels of psychological distress. And more stressful events. And this has been highlighted as a major risk factors why they may be more vulnerable to postpartum psychopathology like a postpartum depression and negative mother-infant relationships. And I think for that reason, these mothers have been targeted for some of the interventions during this time to provide more support. And how the stressful experience during this period of time can be related to the brain changes in the mothers, I look into some literature of the non-human animal work because they can really do elegant work of manipulating their environment. And when they're manipulating the environment with the conditions like unstable and crowded housing, and like kind of material deprivation, meaning that they provide very limited amount of like nesting materials to these rodent mothers that cause these mothers to have more anxiety and have more impaired parenting behaviors, as well as more reduced, altered structural and functional activation in the reward circuitry and the prefrontal cortex. So this seems to suggesting these causal associations, this unstable, a limited environment and stressful environment, and the risks for postpartum psychopathology and the parenting through the brain mechanisms. So, but for human mothers, we don't quite really know whether there could be a very similar story. So we investigated that. So the question is that can stress can get into the maternal brain? Particularly the brain circuitry that are related to parental motivation and emotion regulation. So the first study that we did with the mothers at a range of income status, that what we found was that the lower income was related to reduced prefrontal cortex response when they're listening to baby cry. We typically expect these areas to be have increased activation when they listen to baby cry, but unfortunately, the mothers with the lower income show reduced brain response to baby cry. So in the brain areas highlighted here, the lower income was associated with the lower brain response. This was an important finding for us. However, though, we don't want to stop there, that poor mothers may have a last brain response. It was important for us to investigate more that what aspects of the poverty can be related to the differences in the brain response to baby. So for that, we focused on their experience. So, I've been working with families living in poverty, more than 15 years, and what I see over and over and over about something a little bit more unique about living in poverty or experiencing poverty is that the people are more likely to be exposed to multiple major stressors at the same time. So stress is not unique to lower income people. Like I have stress, you have stress, we all have stress. What's more unique though for the lower income families that they experience multiple major stressors at the same time. And I think that's particularly toxic to our brain and body because it immobilizes us to cope with any one of those stressors because it really overwhelms our system. So, for example, in this, although this is the family with children now, but when we asked them whether they were experiencing any one of these stressors, like exposure to violence, family turmoil, family separation, noise and crowding in their house and housing problem, any one of these are really major stressor for the families. But as you can see here, the black bar is the middle income families that, most of them, maybe like about half of the middle, they do experience one of these risks, right? But it's very rare for them to experience 3 and 4 and 5 risks at the same time. However, the white bar, which is the poverty families, they're a lot more likely to experience 3 and 4 and 5, or actually all of the risk factors at the same time. And this idea is very similar to maybe something that you've heard a lot lately, which is ACEs. The adverse childhood experience. So basically, this is the survey they ask people about how many of these adverse experience they had in their childhood, and there's 10 different items. And the more number of the experiences that people have, it's quite robustly related to more negative health outcomes. So here, the more number of ACEs are related to, more risks for depression, more risks for cancer and obesity, and so on. So it's very similar kind of concept that people experience multiple adverse experiences. It really can impact our health at a multiple level. However, though, the cumulative risk, the other way to call it, hasn't been focused as much for the kind of maternal health outcomes. However, there are some studies suggesting that indeed cumulative risk or experiencing multiple stressors at the same time are particularly a risk factor for, like, for example, postpartum depression. So if you look at any one of the risk factor at a time, it doesn't necessarily increase the risk for postpartum depression. But if you see the mothers who are experiencing multiple risk factors at the same time, they're at a greater risk to experience the postpartum depression. Similarly, the cumulative risk has been related to more parenting stress and more difficulties in the parenting. So in this study that we had 53 first-time mothers were relatively ethnically diverse. And then the risk factors we focused on in this study were 9 different risk factors. So 3 socioeconomic risk factors like low income, financial stress, food insecurity. The other 3 more environmental risk factors like living in noisy and crowded house or the substandard housing quality, and the other 3, the psychosocial risk factors like marital dissatisfaction, violence in the community, and the troubles with authority, like social services. As you can see, any one of this can be major stressor to postpartum women, but we had mothers who ranged from 0 to 8. So there was a mother who experienced 8 of these risk factors simultaneously. And the way that we present it, the measure of the brain activation is that when mother is in the scanner, we play baby cry sound. So one is her own baby cry sound, and then we also have a control baby sound. So I wanted to, if I can, I wanted to play a sample of that. Okay, so that was just a 5-second. Our participants listened to this 20 seconds at a time for probably 20 times in the scanner. So this is a very powerful paradigm to activating the brain areas that are involved in parenting. Makes mom to feel like get up and go to this baby. We have mothers in the scanner teared up. Because they're thinking about their baby. They really want to care for this baby. And what we found was that the cumulative risk was associated with more dampened brain response to the baby cry when they're hearing this sound. So more stressors related to less brain responses. Again, in the prefrontal regions, that might be particularly important for emotion regulation, so as many other things. And another region that also we found was the superior temporal gyrus, which is really important for processing the baby cry. So this might indicating that some kind of brain level challenges of regulating her own emotions when she's listening to her baby crying, if the mother is experiencing really extraordinarily high levels of stress. But also this reduced brain response was related to more less sensitive behaviors that we observed at home when we videotaped her interaction with her own baby. So the last maternal sensitivity with last brain activation. So just for this study that, we think that cumulative risk during postpartum period can be related to more dampened brain response to baby cry, which can increase her challenges to respond to her baby sensitive way. Which is, I think, a reason why we might want to care more about the postpartum environment, because Perhaps it's possible that if we change the cumulative risk or adverse postpartum environment, that we perhaps can change her brain response to her baby and also the behavioral response to the baby so that she can have chance to develop more positive relationship with her baby and develop more deep bonds with the baby. So if I summarize that, I provided some of the examples that perinatal period is a window when the maternal brain may be vulnerable to stress exposure. And one thing that I want to highlight here, though, that because the associations between income is gradient, linear, so that means it's, this association is not exclusive to low-income women. The woman at any income range can be actually influenced by the association between the income and brain response and parenting. Therefore, I think it applies to all women, that I think we should care about all women who are experiencing stress and what that impact may be on her brain and behavioral adaptation to parenthood. And perhaps, cumulative risk or the multiple risk exposure can be target for identifying mothers who may be at a greater risk for like postpartum depression or more kind of negative adaptation to parenting. So, just like ACEs, I put together maybe as an example like 10 different risk factors for the maternal health outcomes based on the literature. So I would love to receive people's feedback and see whether this might be a good idea. But I think just like ACEs, I think we could use something like this to show really in a robust associations between the postpartum environment or conditions and the maternal health outcomes. So those can include, low income, single parenthood, young age, like a teenage mothers, housing and the food insecurity, exposure to violence, like interpersonal violence at home, but also in the neighborhood, family separations, like a divorce or the husband going to jail, for example, history of psychopathology or substance use, or the mother's own experience as a child being abused or neglect. That has been also very powerful risk factors for negative postpartum outcomes. And the last thing that I want to mention is just like I said, I haven't, and I think other researchers haven't had a lot of opportunities yet to show a scientific evidence. But I think we have a reasons to believe that when the brain is receptive to negative experience, it's also receptive to other kinds of experience, like a positive experience too. And during, what we anecdotally notice, I think that others may can speak this better, but, the mothers during pregnancy, they show quite a bit of motivation to kind of change. They want to stop, their drug use. They will say something like, I don't want my child to experience the same thing that I did. But I'm not really sure, whether we're kind of utilizing that opportunity at the best, that, when the mothers are actually quite motivated to make a change for themselves and for her baby. So perhaps, we care so much about these new families and the children, it's important to focusing on providing more positive environment and experience for the woman so that, she is more empowered to provide a safe and supportive environment for her children and the whole family. So thank you.
So I want to say thank you to Joy and Apple for putting this panel together following that amazing research. And I also want to start by saying this is going to be a conversation, and I want to allow for really substantive time to go back out to the audience, because I'm sure a lot of you took in a lot of that information and have some questions for Dr. Kim, but also for our speakers after we have a chat. So I'm going to introduce Dr. Kim, you've already heard from. Araceli Navarro, we're so delighted that you could join us. Moira is not able to join us, so we're lucky Araceli could step in. She is the Associate Director of Government and Community Relations for the Children's Partnership here in Los Angeles. So she'll be bringing the policy perspective to this conversation. And then Dr. Rahil Briggs, who runs Healthy Steps, which is a national initiative housed at 0 to 3. And Dr. Briggs is also a close partner and friend of Ascends. She has been a real leader in the 2Gen field, including in her prior role at Montefiore Medical Center in New York City. So I want to kick off by giving a little context and framing for what 2-generation approaches look like and are. And Ascend is a nonprofit program of the nonprofit, nonpartisan Aspen Institute, which is based in Washington, D.C. And that's important because it was started about a decade ago, and 2-generation approaches are at the heart of what we do, but they are by no means a new concept. You can go back to settlement houses at the turn of the 20th century to see some of the themes of 2-generation approaches emerging. I'm a clinical social worker by training, as you heard from Apple, but I've been at Ascend since 2010 because in my clinical work where I worked in inpatient settings and at an alternative to incarceration for women who'd been sentenced to Rikers Island and separated from their children, I became increasingly frustrated by the systems that these women were in and the limitations that I had in doing psychodynamic and therapeutic work with them. This is generally the point where I give a spiel about what 2Gen is, but I'm going to do something a little different because we have hot off the press, almost literally, a new report from the Frameworks Institute. I'm not sure how many of you are familiar with that organization, but we over the last year have commissioned research from Frameworks to help us sharpen and essentially redefine for the field what a 2-generation approach looks like. And so I'm going to read to you the guidance they shared with us about how to communicate this work to broader audiences, and in particular, what it looks like in the public sector. So for America to eliminate poverty and advance broader well-being, significant changes are needed to the ways in which public policy, public programs, and support services are arranged, funded, and implemented. 2-generation or whole family approaches have emerged as a way that governments can better deploy public resources devoted to early learning, education, employment, health, housing, and nutrition, making the most of these funds by using them more strategically. The 2-generation approach involves identifying the factors that undermine a family's overall well-being and then working with the family to solve problems, access new resources, and sharpen existing skills. A responsive, holistic, family-centered mindset differs significantly from the dominant current approach to public anti-poverty efforts, which rely on a dizzying array of discrete programs, each focused on a specific piece of the poverty puzzle, and each limited to people of a certain age, a certain income level, or other characteristic. Now, thank you. I have to say I shared this with my 19-year-old niece who was like, that's your big idea? How can we not do that already? So just goes to show you that the younger generation is already on board. Couple things I want to note before turning to Dr. Kim with my first question. One, this is about systems not working for families, not families failing. I think this message is also about inherent worthiness and dignity. It's not about who deserves what and when. The other thing I want to note is 2Gen is an imperfect term. We recognize, particularly in indigenous communities, that many of these approaches go 7 generations deep. So we use 2-generation because it is a way of us getting at the evidence around dyadic treatment and where certain innovations are emerging in early childhood and post-secondary education, for example. But I also want to note that with a racial equity lens, other terms are used and are important. And then the last thing I want to note is that in this conversation, as Dr. Kim made the case, we are talking about families with low incomes. We know in the United States that about 44% of all children are living in a family with a low income right now. We know that the racial wealth gap is significant, but we also know that biases exist in the system across income level, and I think Stephen's story really poignantly shows that. So that's a little bit of the context for this conversation, and I want to start with Dr. Kim, since we just left off with you. Can you talk a little bit about how your research, and also your colleague, Dr. Wadamura, who's one of our fellows, regarding neural changes to maternal and infant brains, how do you think that this presents opportunities to meet the needs of children and their parents simultaneously? What do you see as, in the research field, an opportunity to go deeper to learn more about how we can influence practice and policy with it?
So yes, thank you. I think, as a person who do, basic science research, I'm really, welcome to the feedback, people who are doing the policy work. But from the scientific point of view, I think, the amount of the changes in the brain indicates that this is a developmental period for an individual, right? And if it is learning and developmental period, it should come with the appropriate support, just how, we like to support children's brain development. So, because the mother's brain is so plastic, it goes through a really large degree of development. I think it highlights that two-generation approach. That the mothers need the support from others and have opportunity to also show that their own resilience and strengths.
Thank you. So I want everyone in the audience to be thinking about a question I'm going to ask the next two panelists. And that is, what research do you think is missing that would help make the case for the work you are trying to do? Because something that Dr. Kim and I talked about before the panel is that she's presenting research that she is doing, but there may be areas where you actually need more evidence that would be helpful to note for her and for other researchers in the room. But I'm going to go to Dr. Briggs next and talk a little bit about Healthy Steps. So we know that Healthy Steps presents a significant opportunity to maximize the window of opportunity based on the research we've heard. Can you tell us a little bit about the overall goals of Healthy Steps and talk also about the evidence that you're seeing that it's improving outcomes for families?
Sure. Thank you, Sarah, and thank you to Joy and 2020 Mom for having us. The basic idea behind Healthy Steps, which is a national program now in 23 states, Puerto Rico and DC, serving about 250,000 kids and families a year, and on our way to serving 1 million children and families, is that the pediatric practice is an extraordinary platform from which to engage not just children but their parents. Parents bring their children to the pediatric practice. They don't arrive on the school bus. They're not coming on their own. They're always coming with their parents. And whether you look at the data about prenatal care or that postnatal 6-week postpartum checkup, the rates of moms going to prenatal care or that postpartum 6-week checkup are always lower, no matter the group you're looking at, no matter the state, no matter the racial, ethnic, socioeconomic group, versus the likelihood that those same parents will bring their child to the pediatrician. So what an awesome platform to engage in a two-gen, multi-gen way. The idea behind Healthy Steps is that you add a new team member, so it's team-based care in pediatrics, recognizing that pediatricians have about 15 minutes in which to do a well-child visit, and they're asked to do everything under the sun in those 15 minutes, and to really do the kind of relationship-based parent-child work that we're talking about needs more than that, and it's not really realistic to ask the pediatrician alone to do that. So it's team-based care, adding a new team member to the pediatric practice. The vast majority of Healthy Step specialists are licensed clinical social workers or doctoral level psychologists, so this is mental health care for babies and parents together within the pediatric platform. You have 12 to 13 well-child visits in the first 3 years of life, 7 in the first year of life, and again, about 90% of folks regularly attend those visits. The pediatric platform is a trusted non-stigmatized platform. I'm a child psychologist. Talk about stigma. Nobody wants to bring their child to a child psychologist. But as soon as I went and partnered with the pediatrician, nobody said no. So we have a risk stratified way of working with families so that there are both universal services for anyone who walks into the practice, no matter your background, your insurance. All families receive social determinants of health screening and maternal depression screening and child screening, and then risk stratified levels of intervention based on family need. In terms of evidence, there was a national RCT, and there have been multiple site-level studies since then that have shown everything from increases in well-child visit attendance, decreases in emergency room visits, but more importantly, maybe for our conversation today, increases in screening for maternal depression and decreases in maternal depression symptoms. Looking at mothers who have experienced trauma in their own childhoods or adverse childhood experiences, looking at the intergenerational impact on their own children, seeing a real break, a positive break, so that that generational trauma isn't then recreated. I think the best way to sort of tell you about it, I have pages and pages of research findings, but it was such a wonderful talk by Dr. Kim. You can, I'll share these with you if you're really fascinated by that. I want to quickly just tell you more from a parent's perspective what this looks like. This is actually from a Healthy Step specialist in Queens, New York, and she just sent this to me. She said, I met this family when they came in for their newborn son's first visit. They seemed like a happy family, told me all about their 3-year-old daughter who was excited to meet her baby brother. Over the course of the next few visits, it became clear they were not as happy as they had seemed on that first day. Dad moved out shortly after the baby was born. Mom was on her own with 2 kids during the week, and Dad took them on the weekends. As Mom became more comfortable talking to me, Mom opened up about her relationship with her own mother, how confusing and scary her childhood had been. Her mother was mentally ill, behaved in ways that a child could not understand. She had taken Mom to New York from Georgia and left her with her grandmother. Mom felt abandoned, and as any child would, and had no understanding of why any of this had happened. She eventually made her way to the foster care system. You can imagine what that was like. And Mom now found herself being told what a terrible mother she was by her ex, without any family support, and not ever having experienced a positive parent-child relationship. She questioned herself as a parent. She questioned her worth. During this year, she'd experienced a panic attack so severe she thought she was dying and called 911. She also had thoughts of suicide at times, though she was able to contract with me. Mom and I discussed going to therapy on many occasions, and while she wasn't totally opposed to it and acknowledged that she needed help, she didn't take me up on any of these referrals. But luckily, she was willing to talk to me during all of the well-child visits and in visits in between those. We've worked through a lot of her self-doubt and questions about whether she's a good mother. Recently, there was a particularly bad fight. She was at a very low point. We were able to set her up with a mental health screening with one of our therapists that same day, and I got to play with her kids during the appointment. Over the past year, I've watched Mom become self-confident, patient, much more in tune with not only her children, but her own needs. Mom takes time to teach her daughter the kind of behavior she expects instead of yelling at her. And most importantly, Mom values herself and sees the importance of her own life and wants to keep living it. She started taking new steps to overcome her anxiety and depression and is an extraordinary role model for overcoming adversity, challenging stigma, confronting mental health challenges, and taking care of herself in order to take care of her children as best she can. So the basic idea not being, should we do this in OB or peds or psychiatry? We need to do it everywhere. The stakes are too high to argue about where this should happen. This is about integrating behavioral health in the places that families go when they're looking for care.
Thank you. And I think you've also modeled really well how important it is for us when we're making the case for these approaches to have both the quantitative and the qualitative data, because the data and the evidence is important, but the stories matter so much too. Araceli, I want to go to you and talk a little bit specifically about systems change and policy. And it's wonderful to have you on this panel because at Ascend, our theory of change around the two-generation approach is that research and evidence plus parent expertise and voice plus best and next practice informs policy and systems change. So I feel like we've had a natural progression to your perspective. So the Children's Partnership has been instrumental in California in advancing a range of policies for families, not just with low incomes, but with low incomes as well. And I'm curious, how have you applied or are thinking about a two-generation approach in your policy efforts? And then specifically, what lessons are you thinking about from the brain science that Dr. Kim has highlighted or other brain science that has been out there over the last 5 years?
Yeah, thank you so much for having me. This is exactly from a policy lens. What we're hoping to do is that intersectionality between the research, the community, and policy. So we have been working really hard to think about this work. One of the ways, well, let me step back. In terms of social determinants of health, for us, it has been the populations, thinking about the most vulnerable in our state, thinking of the 9 million kids in California, half of them in Medi-Cal. So we do focus on the systems and thinking about how they can better serve children and families. And one of the big research pieces we did that ties very well into this work was immigration policy. We are not immigration policy, immigrants' rights organizations, but we saw immigration policy having an impact on children's health. And so it was having an impact on the toxic stress levels. It was having an impact on their academic success. And so we've been thinking about the research. So in terms of gaps, thinking about where some of that research can come to help parallel with all of the other research that's happening that is impacting kids, children and families' well-being. A lot of it very in line with the ACEs model and again, in terms of what children and families need. So we started doing a lot of research in that space, which complemented a lot of the work that's happening here. And I think for us, it is about making systems work for kids at all levels. And so in terms of the work we've been doing, it has culminated in systems change. So in California, we're very fortunate to have a Surgeon General now, which is a whole new model in the country who focuses on ACEs. And so in this new budget cycle, there is a proposal to come up with a curriculum on ACEs, which is, I think, what that looks like. Fortunately, advocates will play a role in that. But really thinking about what is coming from the research, what is coming from models, to really think through to help people understand what this means. So that's one mechanism. The governor is also an early childhood champion. One of the things that we also want to make sure, in addition to education, often is the case or the vehicle that people think of early childhood, changes a programmatic system. We think health is the one that needs to also be integrated. So really, again, really thinking about that whole child and what the child and family needs. So really, in the budget, again, there is a department of early childhood that's proposed. And for us, again, the advocacy of that intersection between health, education, and social programs. So we're really excited about that. And then in terms of the Children's Partnership, based on research we have done, based on taking into account some of the brain research for both children and pregnant women, we are actually introducing legislation on streamlining enrollment for those who are already in WIC but not eligible, because the system is not in place. They're eligible for Medi-Cal, but they're not enrolled. And so how can we, from behind the scenes, change the system to help families and pregnant women, and again, taking those barriers away from all the stressors that they have in their life? Where can a system, and I really like what you said around making sure that we, the systems are failing us, our families. It's not the individual. So this is an attempt to really streamline enrollment from WIC to Medi-Cal for children and pregnant women. We've had bipartisan support for 2 years. It came down to the money in the last 2 cycles. So this year, we've introduced legislation to really start with the low-hanging fruit of those who are already in the system, and then making sure that we streamline it. The other one I would like to mention about thinking about the whole family and the needs is around medical legal partnerships. There are many that exist in California. There are others that we've learned best practices from in other states. And this is the co-locating or co-integration of medical lawyers or legal assistants in a medical space. So again, that warm handoff, that a non-traditional way of integrating. Our long-term goal is that Medicaid pays for it as a benefit. So of course, in this current environment, we're not moving that forward, but in the legislature and through the budget process, we are going to be advancing that. And then lastly, on the mental health, because kids were internalizing a lot of the stress, it was showing up. We did research on how the immigration policy work was having an impact on the children's, citizen or not, on their mental and behavioral health. They were showing up with stomach aches. They didn't want to come to school, their academic success. So we passed a bill, AB 2315, which looks to bring mental health and behavioral health to a school campus. So the term is telehealth. And really thinking about what that model looks like. We really want to, integrate nurses. For us, it is a whole system of people, and it really is bringing care to where kids are, to move away from the stigma, to make it accessible as we work on the workforce issues. So I'll stop there.
That's great, thank you. And I should say California actually has one of the largest numbers of Ascend Network partners. Our network is focused on mobilizing and partnering with organizations that want to do 2-gen approaches or work. We have 30 network partners in the state of California. There's an amazing organization here in Los Angeles, the Los Angeles Valley College, which is a community college, but they have created a very robust program for student parents with a strong mental health component, looking at that population. So we are frequently looking to California for inspiration right now. I want to ask another set of questions of the group and then actually go out to all of you. So we have about 20 minutes or so for Q&A. It's 2020, and we have an economy that's going very well, but not for everyone. We have a potentially historic, historic presidential election taking place in November. I think that there has been significant reduction in the stigma around mental health, but we have a long ways to go. So I'm curious, from each of your perches, research, practice, policy, and Rahil, you're sort of at the intersection of practice and policy, where do you see the greatest opportunity to impact families right now? Maybe I'll start with you.
Thank you. So to me, I think, again, like providing the environment for all mothers to parent their children that is safe and supportive. So one of the things that I think it would be important would be, for example, like paid parental leave, that the duration is appropriate for building really deep emotional bonds. And something we see in our data, and I noticed there are some other reports, is that, now we study mothers from the first trimester and the postpartum period, and there is a really deep in their income level right around the childbirth, especially for low-income women, because they're working at a places that there's no parental leave policy, not to even mention paid leave. The only option they have is to quit their job, and especially mother who's also single mothers, doesn't have a partner who can provide income. They were already at a low income status, and then their status really dipped right around time. And I can only imagine the kind of stress and adversity that they have to experience during this period of time. And then the other part is, I think what we just talked about, I recently heard a very powerful analogy that used by a professor at the UNC, that how perhaps in the system we treat our pregnant woman like a candy wrapper. So candy being a baby, that during the pregnancy you pay all attention to the pregnant woman because of that candy. But once the candy is out of the wrapper, what do we usually do with the candy wrapper? We just toss it away. So all the other attentions and the policy support in some regard, like a Medicaid, are focusing more on babies rather than the postpartum women who are still dealing with the medical issues and the mental issues. So I think those will be some of the focuses for the future.
Thank you. For us, definitely, the census is a big factor for 2020 as well. Children are actually the most undercounted, have been the most undercounted population. So certainly for us, it's that intersection between informing community and letting them know what it means. So the long term is it changes congressional seats for California. Again, representation of our population. And also, it has implications for long-term investments in terms of the population. And so the other is for them to know their rights, both healthcare rights, both legal rights. There is proposals to changing, laws and such, but the chilling effect has been really impactful, again, on a toxic stress level to our children and families. So really thinking about what truly is law and what is proposed. We've had to do a lot of educating and engaging families and understanding what a regulation versus a proposed bill versus a budget is, and which is part of the civic duty, I think, as well. So we're exploring ways of, again, as we do our community engagement, to make sure that families know what they're protected by, and then as well, how to get informed, engaged.
Thank you, Araceli, for giving two, because I felt bad that I was going to be cheating, but you laid the groundwork for me. Payment for prevention is a critical piece. We struggle in this country. We pay when you have a diagnosis in mental health, and we do not pay when you don't have a diagnosis. And what's been pretty extraordinary over the last couple years is that the Healthy Steps National Office, in conjunction with Manat Health, we've developed a business case that shows that year over year, you've got a very positive return on investment when you intervene in this two-generation way. Across 4 different states now, looking at an average return on investment of about 200%. Invest $1, get $2 back. How does that happen? Well, the kids are more likely to be vaccinated and go to the dentist, but mom's more likely to get attention for maternal depression and interpersonal violence. Payment remains a challenge, and what I have started to think a lot about, and especially being here in California, where I don't know if you all realize what an extraordinary time it is in your state. From not being in California and looking into California, it's like, wow, this is a real moment, with a governor who's committed to early childhood and a Surgeon General who's committed to ACEs and the like. $69 for every developmental screening and $29 for every ACEs screening will be paid in California by Medi-Cal. That more than pays for a program like Healthy Steps, which only costs $100 per family per year. Our data systems, though, I know this isn't sexy, but stick with me for just a second. Our data systems do not allow for you as a pediatric practice to extract the data that shows that you did those screenings, right? Epic has 50% of the market share. This isn't a knock on Epic, but they're just the biggest. So when you're out in front, you get things thrown at you, right? You cannot document a child developmental screening, an ACEs screening, much less a maternal depression or an anxiety screen in a standard template. And if you can't document that screening, then you can't pull out proof that you did those screenings, then you can't pull down that $69 or $29, and you lose this extraordinary opportunity because people say, well, hold on, we paid $69 or $29 and nobody did the screenings. Nobody was able to extract the screenings from their medical record system. So I think we have to stay focused on payment, but also really recognize the barrier that the data system creates for showing what was done, extracting it, and pulling down that payment.
And I think that granularity is actually really, really important because it's where the rubber hits the road when we're talking about, big frameworks and approaches. How does it get done? And I will say, there's huge momentum for two-generation approaches across the country. The biggest challenge for us to move out of a proof of concept phase into, demonstrating that this is evidence-based is around the data. And not that there isn't emerging, aren't emerging outcomes for children and the adults in their lives, but how do we integrate that data to show that it's correlative and causal? So we have not fully cracked that nut, although we are actively working on it. I want to go out to the group because you've heard a lot of us talking, and I'm sure you have a lot of questions. And as we move into Q&A, I just have two quick requests. One is that you introduce yourself and tell us who you are and your affiliation. And the second is that, if possible, to avoid using acronyms when you ask your question or share your comment, because we're all coming from different perspectives and expertise. Who's up?
Okay, we collected the questions, actually.
Oh,
so
excellent.
people will not be able to introduce themselves. Sorry about that. And we're going to go back and forth between questions in person and online as well.
Perfect.
So here's the first one that we have for the policy person. Who are you paying closest attention to in the governor's proposed budgets? Biggest impacts, and what should we focus on? Small question.
Hard. Yeah. As stated, I mean, this is a governor who is changing systems. There's, and I apologize, but they just changed the name, the CalAIM system. It's essentially the reform of Medi-Cal, of DHCS and the systems. And so there is work groups, and one of our challenges with this new effort of changing how Medi-Cal functions in California is that it comes from a high-risk whole child, whole person lens. And we want to make the argument that we should come from a prevention space, that we should not wait until kids are high need, high risk users, which are more costly. The data shows such case, and really think about from a prevention lens, what can our state do? There's a slew of items under that category. There is also, for us, it's in talking about 2Gen is Health for All. So Health for All is another big, long-standing effort that's been happening in California. We were able to get Medi-Cal full scope for kids in 2016 up to the age of 19. Last year in the budget up to the age of 26, and this year we're hoping to include seniors. So in really 0 to 3 has actually done research on the benefits of having grandparents covered and the implications, in terms of that to a whole family and as child caretakers, as family members, and again from a lens of just humanity. So there is the element of the ACEs curriculum. There is other efforts around developmental screenings. So we're monitoring a lot. And then, as I mentioned, the additional pieces that we will be asking for in the budget are tied to legislation.
Great, thank you.
All right, here's another question, and this is asking, in the research where mothers with reduced brain response, what other types of behavior was observed?
So the behaviors that I focused on in that study was looking at the mother's interaction with her own baby. And unfortunately, during that short period of time that we were observing the mothers, on average, that the reduced brain response was related to less sensitive. So the way that we measure is like, how many times she smiled appropriately in the interaction, how many times that she spoke appropriately in that context with the baby. So those are what we observed. The mothers who tend to participate in this study are, even though they're in the very stressful environment, but they are otherwise doing pretty well. And the next step that we focused on is studying the mothers who are relatively struggling even more. That, like, for example, mothers in the clinical level of depression. So that will be the next step.
Great. So this is from someone who's either streaming or on a webcast. This is Whitney Plantia. First of all, said that the candor wrapper analogy was really helpful and a great analogy, unfortunately, I guess. But the question is, do you see changes in the Violence Against Women Act impacting higher stress levels and increased ACE or risk scores?
Yeah, I mean, yeah, okay. So apparently there's a panel, so please check that one out. But I would say yes. I mean, again, just based on what we're seeing, and again, I make the parallels to immigration policy because family separation, when we think about the ACE metrics, we TCP argue that immigration is one of those metrics that's not accounted for. And it's because of the family separation. So again, some of the trends and behaviors that happen as a result of policy, so in terms of the act, if at minimum, I would say the chilling effect implications of what it could mean has an implication on health. And so I could anticipate that, but most definitely I defer to the group tomorrow.
I would just add that with our network, the Adverse Childhood Experiences study and the way in which it's been rolled out has been very, very powerful for a lot of organizations looking to do 2-gen work. I mean, what Nadine Burke-Harris has done over the last 5 years is really incredible. I would say that we have a lot of partners who acknowledge that it's a tool, and if you want to use the tool well, you have to have investments in professional development and staff time and training and, understanding of secondary trauma. So I think when we talk about ACEs, we need to be mindful too of the way in which there has to be an ecosystem in an organization to support what comes out of using the tool.
Great, thank you. This is another question from online from Vanessa Lopez in Stanislaus County. Is there a research study that provides information on return on investment when providing mothers with the mental health needed to secure parenting, reduce the stress, and increase bonding?
So an ROI on the investment in maternal mental health, essentially for both generations. Do you want to talk a little bit about that?
Sure. As I mentioned, this business case work that's done is looking at the cost to the state Medicaid authority when maternal depression goes untreated, and then comparing that to when you're able to go ahead and treat that. As I said, when you're looking at a 200% return on investment, the vast majority of that is on the mother side. You're not recouping a lot of ROI on the child side because kids are pretty cheap to start with. They don't cost the system a lot of money, right? So there's been a lot of effort that really looks at the costs to the system. It's monetizing something that most importantly is a cost to a family and is at a human level. But in terms of the data and the research, we have to sometimes look at it in terms of a cost level. And you can see that 12-month year-over-year cost savings when you're able to intervene on the maternal depression. I think as Stephen very accurately said, we also need to expand our focus to anxiety, the acronym being PMADS, the parental PMEDs. Perinatal, all at once now, perinatal mood and anxiety disorders, to really recognize the full breadth of what folks are looking at.
Thank you. And I would just add to that too, across the 2-gen field, there are some programs like one coming out of Head Start called Career Advance in Tulsa, Oklahoma, where this is a long randomized control trial looking at parents who are enrolled in intensive mental health as well as workforce training, and then the control group of parents who are not. And that study is showing that the attendance rates of the children of parents in the Career Advance program, which has a mental health wraparound, are higher than the attendance rates of children of parents who are not. The hypothesis being that child outcomes may improve when their parents have access to those supports. Again, it's very intuitive, but that's the kind of evidence that we need related to the question. Other questions?
Thank you. Yes, we have lots of questions. Thank you all. Oh, no. 10 minutes, yeah, 5 minutes. We won't get to all of them. We'll do our best. So this question is asking about the intersection between brain structure, behaviors, and environments, and says, how do we account for the unique strengths that also exist in low-income families? And as a second part of that, how do we account for different cultural expressions of attachment between mothers and babies?
I'm happy to take a piece of that, but I think Dr. Kim can speak very intelligently to it as well. Epigenetics is so important, and epigenetics being the intersection between environment and genetics. Looking at basically, you can have a genetic predisposition for something, say schizophrenia, and the environment that you're in has an influence on whether or not that happens. Most importantly, we're learning so much about the differences between children when they're born and their risk susceptibility. Anyone who has more than one child knows that they kind of came out probably a little different from day one, right? One cried more and was harder to drop off at kindergarten and just was more fussy, and the other one kind of nothing phases that kid. The orchid and dandelion metaphor that's been put forward by Tom Boyce and other wonderful researchers. Not a perfect metaphor. We're not either all orchids or dandelions. A continuum, but being the idea that you are somewhere along this very resilient, not that susceptible to the environment, i.e. a dandelion. Dandelions grow in the cracks and they grow anywhere, but they're always kind of going to be dandelions, right? Or exquisitely sensitive, the orchid. And in the right environment, the orchid blooms. And in a challenging environment, the orchid really suffers. There are vast strengths in families, and poverty alone is not in and of itself, a necessary barrier to children really flourishing. I grew up in Colorado. That poverty level was way above where my family was. I grew up in the poorest county in Colorado. I get to be the national director of Healthy Steps, right? Was I a dandelion? Maybe, but I also had an extraordinary preschool system, and there was a doula at my birth, and there was a real focus on early childhood. So it's just to say we're learning so much about the individual differences that really seem to be from birth and from the perinatal environment potentially that are really helping us understand which children and families might benefit from the most intense interventions.
That's an excellent question. So in terms of resilience, the most of studies more focused on children's resilience, and the couple things that from that literature has been pointed again and again are supportive parenting and higher cognitive functioning. So for mothers, the resiliency literature has been more limited, but the thing about the kind of cumulative risk that I talked about, the other side of that, the mother is having more stressor means that they have a less resources to use to cope with, like less resiliency. So I think the the focus should be that, finding the ways that, not all mothers develop postpartum depression. So those mothers, who do relatively well in a difficult situation, for example, like what are some strengths that they have in them can be, their childhood background and so on. I think will be really important things to study. And in terms of the mothers from the different cultural background, I think that's something that really needs to be understood better, that there is a system that I feel like not giving the equal right to all mothers to have the children that they want, not to have the children, or to parent a child in the environment that they would really like. So, immigrant parents, parents with the minority background, I feel like, some testings, like, when the child's birth, whether the child will be tested for the drug or not, I think it's a good example of how that's done without the mother's consent, and it's done for only selected mothers, which increase the risk for mothers to lose the baby. I think this is just some of the examples that there's a system that we have that put a lot of mothers in an even more disadvantaged position and not having the right that they deserve. So I think those are really important questions. Mm-hmm.
So we have a question at the back that I know we want to get to.
I've been waiting patiently. My name is Heather. I'm from First 5 Ventura County, and I felt a need to speak up today in the absence of Moira from the association not being here. And I know that the majority of the folks in this room are focused on moms, particularly, obviously. But on behalf of First 5, and this is mostly targeted at our policy person up there, but the prevention is the key, and you spoke to the work that's being done in the K-12 system, but again, that doesn't always get to the littlest ones. And we know that that's directly connected to the mothers who are experiencing postpartum depression, et cetera, and the attachment that's formed with our youngest children, that's not necessarily being discussed yet. I think in addition to that, there is this, California is at fault for this, actually, but this medical necessity that comes out of our behavioral health systems that is never intended to be targeted at the youngest children, and our 0 to 5 population is continuously left out of that system, right? And while some of those systems may not need to target the child specifically, back to the 2-generation approach about doing things with the youngest children and their mothers, locally in Ventura County, we're doing these parent-child together classes, and that's what it's intended to do, is to bring any caregiver with their child to give parents a forum and caregivers a forum in which they can connect to other people and reduce the social isolation that happens, in addition to getting education for their children and the bond that's happening directly with the parent and child. So I just ask that we continue to stay focused on the youngest children too, and not forget that there's a vast majority of children who are not in the K-12 system, and the preschoolers are struggling in our systems. They have challenging behavior that, again, the behavioral health systems are not addressing, and so.
Thank you. No, I think that's a really important reminder. I don't know if, Arcelia, you had anything you wanted to respond to.
No, most definitely. So I didn't get to 2 other parts of our build portfolio. So actually, our president is on the Mental Health Commission for California, and one of her intentions is to really bring to light that children and that 0 to 3, 0 to 5 component is often missing in the conversation. And in terms of thinking about early childhood centers and entities that support children, pregnant women, and families overall, we are working on legislation to think about what the information, training, and services are available there to raise the elevation. And I imagine the ACE curriculum will be also a place where we will advocate to make sure that it accounts for that population.
And also not just low-income families, right? Because we know that all these kids who are not connected to the Medi-Cal system are still having other issues that happen, and they get left out. Even when there are changes to the system at that level, they still get left out of that larger circle.
Just
Do you have a
very
response?
quickly, we have so much focus in this country on universal pre-K, like that's going to solve all these problems, right? We have all these children showing up to kindergarten not ready to learn, and somehow just moving that 1 year forward is going to solve all of our problems, when actually what we're going to have is a lot of children showing up to pre-K not ready to learn. For your exact point, that this real opportunity, back to this really moment and window of opportunity, is within these first 3 years of life.
Thank you. Well, I think that that is our cue to transition to the break. I want to give a round of applause for our fantastic speakers. Thank you. And just make two quick notes. One is the work of Dr. Kim and her colleague Sarah Watamura are found in multiple places, but notably in a report called Two Open Windows, which is available on our website, and it captures not just some of the research she shared, but also some practice and policy recommendations. So you can find that on our website, and I'll share it with Apple for the app. And then the second thing I wanted to note is at Ascend, we have an innovation community called the Aspen Family Prosperity Innovation Community. It is supported by the Robert Wood Johnson Foundation. Last week, we released a letter of intent, and we're seeking responses for a $2.6 million fund. We are seeking to fund up to 20 organizations around the country that are working at the intersection of work-family supportive policies, mental health, employment, childcare, on behalf of families with low income. So I suspect there is some of that work happening in this room, and you can go to our website to learn more about that funding opportunity. Thank you so much.
Thank you, Sarah, and the rest of the panelists for this very engaging conversations. As a pediatric therapist myself at a children's hospital, I can really attest to the urgency of the two-generation approach.
But I'm going to go ahead and introduce our next panel. First, I have the pleasure of introducing Yasmin Reagan, whose little ones you can hear in the room here today. Yasmin is a mother of two boys, Maddox and Alfie, and she was diagnosed with postpartum depression and anxiety in May of this past year, and she's still battling some of these struggles as we speak, and we thank you for being here and being willing to share your story. Yasmin is advocating through social media for mothers experiencing postpartum mood disorders. We're so glad you're here. I'm next going to introduce Dr. Phillips. Megan Phillips is a licensed psychologist in private practice here in California in Orange County. She's also a survivor of postpartum depression 2 times over, as I think so many women in the room may be, or those listening online. She became acutely aware of the lack of properly trained providers to treat these disorders, and she earned her perinatal mental health certificate from our partner organization, Postpartum Support International. Thank you, PSI, for developing that certification program for experts in maternal mental health. She has grown her practice to have 2 locations and 5 clinicians in her practice. We thank you so much for joining us, Dr. Phillips. And for those of you who were with us last year, you might remember that Dr. Phillips stood up while she was actually pregnant and asked some difficult questions of one of the other guests on our panel. So it's going to be a fun conversation today. So we thank you both. Next, I have the pleasure of introducing David Lloyd, who's in the middle here. David is a senior policy advisor at the Kennedy Forum. Many of you may know the Kennedy Forum is a nonprofit sort of think tank addressing mental health parity, or mental health policy, including mental health parity legislation nationally, and supporting states in developing policy as well. Mr. Lloyd has served as a legislative assistant to the U.S. Senator Debbie Stabenow, and also served in a variety of leadership positions working on mental health policy. And we're so thrilled that you're with us and that the Kennedy Forum is represented. I also have the pleasure of introducing Tim Clement. Tim is the Director of Legislative Development at the American Psychiatric Association, the APA. He's an expert in both federal mental health parity and addiction, and the Federal Mental Health Parity and Addiction Equity Act, MAPIA we call it, and similar state MAPIA laws. He has drafted model legislation pertaining to mental health parity and also the psychiatric collaborative care model, which I'm really interested in learning more about as well. So we're really thrilled that Tim, with his deep-rooted expertise in mental health parity, is with us today. And then finally, I'm introducing Dr. Stuart Lustig. We heard a little bit about Dr. Lustig coming from Cigna, and you all may remember Dr. Lustig has been with us in the past, so welcome back. He's currently the National Medical Executive for Behavioral Health at Cigna. He engages with clients, provider groups, and other stakeholders, and he is a board-certified psychiatrist specializing in child psychiatry. He's also served as the lead medical director for child and adolescent health for Cigna and various issues. He's really fantastic in serving his community in multiple ways in the San Francisco area. And also, you may recognize him from television because he is featured in several of Cigna's ads around mental health and well-being. So welcome to you, Dr. Lustig. It's great to have you. So up next, we're going to pull up the PowerPoint that we have both David Lloyd and Tim Clement presenting today. And you're going to get, I hope some of you feel like you have capacity to be a bit of a policy wonk, because we're going to hear a little bit about federal mental health parity law today, and it can be complex, and they're going to do their best to give us all a good foundation. We're going to talk, though, not just about current federal mental health parity law, but access in general and the struggles around access in mental health, and talk about some potential new levers around policy on this panel. So we're really excited to have you. And Sydney, if you don't mind helping us pull up the next PowerPoint, that would be great.
Good morning, everyone. It's a pleasure to be here. And so David and I are going to talk a little bit about just the concept of parity, the federal law that exists, and a little bit of the history as well. This can be a very dense issue, so we don't want to bog you down in the weeds. We'll just get into some of the broad contours of the law and the concept, and then move on from there. So as you can see, the basics, it's a very, very simple concept, the parity is, that mental health and addiction insurance coverage should be no more restrictive than insurance coverage for any other medical condition. So I think at its heart, it's a very simple and easy to grasp concept that the illnesses of the mind should be treated and covered the same way as illnesses of the rest of the body. However, you might be asking yourself, okay, well, if it's so simple, why did we need a federal law requiring that there be insurance coverage that was no more restrictive? And that's because historically, mental health and addiction insurance coverage was much, much, much more restrictive than it was for other medical conditions. This is something that was basically true throughout the history of mental health and addiction insurance coverage. For instance, very frequent up until the federal law that passed in 2008, there were strict limits on how many days you could be in an inpatient mental health facility or addiction facility, strict limits on how many visits you could get to a psychiatrist or a psychologist or any other mental health or addiction professional. Oftentimes, co-pays and co-insurance for mental health and addiction insurance coverage were much more expensive, or you'd have co-insurance for mental health and addiction that would be a much more expensive thing, and you'd have co-payments for other medical visits. And then one thing that was very, very common was a separate deductible for mental health and addiction insurance coverage. So you'd have your regular deductible for medical care, and you'd meet that. But then when you needed mental health treatment, you have to get another deductible. And sometimes that deductible would be more expensive than your deductible for other medical care. So that's sort of the historical context of why there was a need for federal and state action on this issue. So if you want to look at the history of parity, it actually goes back pretty far. So back in 1961, President Kennedy, President John F. Kennedy, he required the federal employee health benefit plan to have parity with other medical conditions. So it was basically, that was sort of the first step. And it's not a surprise that you'd see a Kennedy sort of lead the way on this. The Kennedy family, they've long been strong champions of mental health, and treatment and coverage. In fact, the last act that President Kennedy ever signed into law was the Community Mental Health Act in 1963. So in 1961, President Kennedy established that. However, unfortunately, through future administrations, that got scaled back a bit extensively in 1975, and by 1981, it was completely gone. Then our next major step was in 1996. Congress passed the Mental Health Parity Act. However, this was a very limited and almost superficial change. It really had very minimal requirements, and of course, it only applied to mental health coverage and not addiction coverage. Then in 1999, President Clinton basically redid what President Kennedy did in 1961. He required that the federal employee health benefit plan be at parity for mental health and addiction coverage with other medical care. And then, of course, the big game changer was back in 2008, Congressman Patrick Kennedy, David's boss, my former boss. Oh, sorry. Back in 2008, Congressman Patrick J. Kennedy, David's boss, my former boss, he sponsored the Mental Health Parity and Addiction Equity Act, which was signed into law by President Bush. And that required initially all large employer plans to comply with, to have parity for mental health and substance use disorder coverage as for other medical care. And the big thing here was also it extended the coverage to substance use disorders, whereas previously parity had just been something for mental health coverage. And then in 2010, the Affordable Care Act built on that and extended the parity law to individual plans and small group plans. So an additional 63 million Americans now had parity protections after that. Then finally, in 2013, the final regulations for the federal law. So one thing that happens with laws and legislation is once a piece of legislation is passed and becomes a law, oftentimes there need to be regulations issued by federal regulators to add in some specifics. So that took place in 2013, and that's really where the bulk of the requirements of the federal parity law are contained within those federal regulations. And then in 2016, those regulations were extended and issued for Medicaid as well. So just getting into some of the specifics here, we won't get too deep into any of the terminology here, but there's some broad components of what the federal parity law requires. Basically, it's mental health and substance use disorder must be compared to medical and surgical benefits. There's three major buckets. One is financial requirements. Those are things like co-pays and co-insurance and deductibles. The law has very specific requirements for that. It also has requirements related to quantitative treatment limitations. Those are the hard limits on care that I mentioned earlier, like inpatient day limits, outpatient visit limits. And for these first two buckets, the insurance industry, I think, has done an outstanding job of coming into compliance with these issues here. I think you see some of those restrictions that we used to see in place, like more expensive co-pays or hard visit limits and day limits. Those things have mostly disappeared thanks to insurers coming into compliance with those aspects. And then the last part of the law is it requires something called non-quantitative treatment limitations, a very complicated term. And David's going to talk a little bit more about that, but mostly what that refers to are insurers' managed care practices, like things like prior authorization, how they design their networks, how they set reimbursement rates, and many other things. So the law has very specific requirements as it applies to those managed care practices. And basically what it requires is they be comparable and no more stringent for mental health care than they are for other medical care. The law also groups everything into separate classifications of benefits. You got your inpatient classifications, your outpatient classifications, prescription drug and emergency. That's where all the parity analyses must take place. And of course, one thing that's very important to note is the law requires compliance both with written materials, but also how things are done in operation. So for instance, if you have a prior authorization, let's say, for someone who's in a mental health facility or being transferred to an inpatient unit from emergency department, the way that prior authorization by the insurance company, the way it takes place, has to be no more strict than what happens when there's a prior authorization for other medical care. And that's an aspect of the law that can be quite challenging to implement. But I'll stop there and pass it over to David.
Great, thanks, Tim. And I'll talk a little bit more in detail about these, the managed care practices, these non-quantitative treatment limitations. So as Tim mentioned, it includes things like prior authorization requirements, provider networks, setting reimbursement rates. Basically anything that doesn't fit in the other two buckets fits in this bucket. So any managed care practice that limits treatment that health plans use. And there have been several reports that we think show that there are still problems in this area. And we continually hear that from people who contact us that they're having problems with managed care practices that seem, at least on the surface, to perhaps be problematic from a parity perspective. But the actuarial firm Milliman did a report both in 2017 and then in November of last year that looked at how often patients had to go out of network for mental health and addiction care compared to other types of health care. And they found pretty dramatic disparities in how often people had to access care out of network. And that, of course, means that because out of network care has higher co-payments, higher deductibles, et cetera, that you're paying more out of pocket. And the cost is really borne by the patient, and it's hard to find the care they need. So that is also kind of under the Parity Act kind of covers these issues, and in many states, it was the disparity was 10 times more often people had to go out of network for mental health and addiction care compared to medical surgical care in inpatient and outpatient care. So health plans are required under the Federal Parity Act to actually do analysis that shows that they're in compliance. So they basically have to say, what are our practices on the mental health and addiction side, what are our practices on the medical surgical side, and do a comparison to make sure that they're in compliance with the law's requirements. Unfortunately, we think that that isn't occurring as often as it should, or that isn't plans aren't meeting the requirements of the law. At least some plans. But this can be a very tricky area for consumers to police themselves because they simply don't have the information that they need. So they may they're not experts in mental health insurance law. They're not the denial letter that they might get might not provide enough information. They might not get requested information that they request, even if they should get that information. So we're really focused at the Kennedy Forum, the American Psychiatric Association, at getting state regulators to do more to ask for the parity compliance analyses up front to make sure the plans are compliant, so that we're not relying on people who are in crisis in emergency situations trying to find the wherewithal to complain while they're trying to keep either themselves or their loved ones perhaps alive, that they also have to try to complain to the Department of Insurance in their state. So that's one thing that we're pushing and that we think is important to proactively ensure compliance. And finally, there is, I won't get too much in the weeds here, but enforcement is both done at the federal level and the state level. So many different types of plans, especially for large employers, like large corporations, the oversight is handled by the federal government. For many other types of health plans, including for Medi-Cal in California and Medicaid programs across the country, it's primarily a state function that oversees parity requirements. So I won't go into the weeds there, but just know that there are different regulators who handle different types of plans, and it can get kind of complicated. But so we're working with both federal regulators and state regulators to try to improve compliance. And really, the goal is to make access to care a reality so that people can get the care when they need it. And the good news, though, is that state regulators in particular are becoming more engaged. I was very pleased to see that Governor Newsom a couple weeks ago made parity compliance a priority in his state budget address, which is very positive news. In other states, they're actually requiring that plans submit this comparative analysis up front so that the regulator can see if in fact the plans are compliant. So we think we're making a lot of progress. And additionally, the main National Association of Insurance Commissioners is making progress on this as well. So we're gathering momentum, but we know there's still a long way to go.
I just want to comment briefly that to me this is a great example of when policy really matters. If insurers wanted to do some of this work on their own and might know that this was important, they would feel like it was difficult to adopt these kinds of policies, because what if, for example, Cigna decided we want to do much more of this, but other insurers did not? It's called adverse selection. So we might have more sick patients, come to Cigna instead of distributing healthy and sick people and patients more uniformly. And so it's important to have this sort of foundation. This is where policy really can make a difference. So thank you to the Kennedy Forum and to each of you who are really paramount in ensuring that these laws were passed. Wonderful. Well, I want to start, and you heard today that we learned actually from
a double board certified psychiatrist and pediatrician when we started this work 9 or 10 years ago, to always start with a story, like lay the context with a story. And Stephen, amazing to start the day out and the event out with your story and your access struggles too. And I wanted to invite Yasmin to join us on stage for this panel. What we're finding, of course, is that social media can be an amazing way for us to connect. And we as 2020 Mom hear often from mothers who are struggling with access through social media. And we had the opportunity to hear from Yasmin about 4 months ago, about some of the struggles she was having with access. And I felt it was really important for her to come and tell her story on this panel. And so I'm going to turn it over to Yasmin now. And I think we'll pass one of the microphones down, if you don't mind, to just tell us a little bit about her journey.
My name's Yasmin. I was asked to do this back in October, and I was for sure thought I would be ready until right now.
Isn't that a is that not?
That's a beautiful accent, isn't it? And so we're going to ask her to tell a little bit about where she came from and how she got here too.
Yes, I'm definitely not American. I've been in the States since 2012. I'm originally from Australia, and it's probably going to be really thick because I'm trying to get my point across. When we were talking about certain risk factors for PPD, I was never presented with, do you have this, do you have this, have you had this trauma? And so when I was diagnosed, I was completely blindsided. So going back to that, I was originally married to someone that brought me over here with a wonderful life and everything, and he was extremely abusive. So I left him because if I didn't, I don't think I would be here. So I know for sure that that played a huge factor in me getting PPD. I never got therapy or anything like that after that. So that's what brought me over here. So I am now happily married to my husband, and I got the 2 babies over there. So basically, I'll start on my story, and I'm going to try really hard to hold it together. I had Maddox in January of 2018, and I never forget, he was a week old, and I had my mother-in-law holding him. And I just felt like I was shaking, I was sweating, I knew there was something not right. I just knew that this was more than first-time mum. But due to lack of maternal mental health education, I told myself it was neurotic first-time mum, I'll get over it eventually. I didn't. That then in turn turned into postpartum OCD, which is not spoken about as much as it should, because postpartum OCD can bring on those intrusive thoughts that a lot of mums unfortunately experience. So I've had this for 2 years, almost just over 2 years. I got pregnant with my second when Maddox was 7 months old. So they're 16 months apart, and this is when it starts to get hard, because around 30 weeks, I started experiencing depression, and I've never felt depression a day in my life. I've always kind of been the positive person, and I was getting fits of rage. My dog barking was enough to just send me over the, I couldn't handle it. So I went to my, you can hear me talking. I went to my obstetrician at 30 weeks and I said, I think I have depression. I think there's something wrong with me. And he said, okay, let's have the baby and we'll go from there. So I had Alfie at 39 weeks due to high blood pressure. So that was an additional 9 weeks of me suffering and thinking it was all in my head. So I remember I was heavily pregnant, probably about 38 weeks pregnant, and I said to my husband, there's something wrong. I don't want this baby. I want to have him and just leave him in the hospital. I don't think I can do this. And that's when I knew for sure there was something wrong, because all I've ever wanted was to be a mum. That was just my calling. So nonetheless, I had him, and that's when it started. They hand you a child, and 2 children. Maddox was only 16 months. And he knew that I had depression and showing depressive symptoms, and I called every single day for 2 weeks to get an appointment because I knew that I had PPD. This is so hard to talk about because I was literally fighting for my life, and I had to fight to get an appointment with my doctor. So I called and I said, I think I have postpartum depression. So the nurse gives me a bunch of random intake questions, and she asks me if I had thoughts of harming my children or myself. Thank you. My makeup's going to get all messed up. It's the first time I've worn makeup in forever. I'll just take these off. She asked me if I was going to hurt myself or my children, and I knew I would never hurt my kids, ever. But I had thoughts of harming myself because I felt like such a goddamn burden, and so like I was failing everyone, and I was too ashamed to admit that I had those thoughts. And she said, oh, that's okay. You don't have postpartum depression because you're not having suicidal thoughts. It's just the baby blues. And I swear to God, those words will forever stick to me because I know my body, I know my frame of mind. So she said, go and relax, take a nap. Because that's so easy to do with 2 kids. And then she said, try not to worry because the stress can pass on to your breast milk. And she was a nurse at my obstetrician's office, so if you've got a nurse at your OB's office telling you that, there's something wrong. So I was like, okay, I'm going crazy, that's it. And my suicidal thoughts got worse and worse and worse because I literally thought I was going crazy. Nonetheless, I fought like hell because I have 3 people that are relying on me. And I got that appointment. And he again asked me if I was having suicidal thoughts. And he said, before you answer, if you say yes, I have to commit you to the psych ward right now. I had a 2-week baby who was breastfeeding, and I had my oldest and my husband who's a shift worker, so you can't just... So I lied because there was no way in hell I was going to go to the psych ward and be treated. Like, I was crazy because I'm just a mom. I'm not crazy, you know? I don't need my belt taken away from me or my shoelaces taken away from me. I needed help. So he put me on Zoloft, which did nothing. And he said, I'll start you off at 25, but, you know, cut the pill in half to get used to the antidepressant. He says, but don't use that knife to slit your wrists. You'd think I was making this up, but I'm not. So then I started Zoloft, and I went into therapy, and she was the only person that could get me in because she accepted my insurance, and she claimed that she was well versed with postpartum, but I'm going to tell you right now, she wasn't. Because the first time I met her, she told me to stop breastfeeding because it can be a huge contributing factor to depression. PPD, I'm sorry. And little did she know the reason why I was continually, and so I'm still breastfeeding now, is I thought I could rewrite the bad thoughts that I had in my head when I was pregnant with him to just make them go away if I breastfed him. So being told you need to stop breastfeeding was not good for me. So I went to her for 4 months because I had no other option. In between those 4 months, I was fighting with my insurance company because they wouldn't allow me to go and see a postpartum versed therapist. They told me that I could just go and see anyone that accepted my insurance, but obviously when you're dealing with intrusive thoughts and everything, people automatically think that you're crazy and you're trying to rationalize with a professional, and they make you, think that you are actually crazy. So I found my therapist through Joy. She helped me so much. And I'm now with her for a couple of months, and she has been able to open up a whole different level of what I'm dealing with. And I don't think I would ever be able to get this far without someone that obviously isn't well versed with postpartum depression. So it's a very long-winded story, but I'm just trying to keep it short. But basically now I'm almost 9 months postpartum and I'm still struggling. Every day is a challenge, but I still get up and obviously show up for my family because, and I'm also advocate for a lot of mums on my social media page because Stephen, I knew about you, and I had Alexis in mind because I wished that she could go on a page like this and see that she wasn't crazy. So she is my drive. And I've never said that before, but I actually posted a picture of her and your daughter and said that she is my drive to make sure that we don't lose another woman because of cracks that are so damaged. Medical practitioners need to be more educated. And if I have to stand in front of every single doctor in America and tell them that they're the ones that are crazy for thinking that intrusive thoughts are crazy, I will do it. So, thank you for listening.
How lucky are we to have Yasmin here? I'm going to do that too. One of the things that I want you to know is there was a lot of work trying to navigate the insurance system behind the scenes with Yasmin. It wasn't Cigna. Another behavioral health care company in New York, who's actually is trying to do a lot of work in maternal mental health, but not one single provider on Yasmin's panel that had received training in maternal mental health. And so she's seen someone now out of network and has received commitment from us and her therapist that we're going to figure out a way to make it work, but this shouldn't be the way it works. So I want to start by asking Dr. Phillips to talk just a little bit about what you see and how patients are able to access care. And I also, again, want to acknowledge that there's been incredible policy work that really, the way I frame it with mental health parity is it's sort of benefit parity between medical benefits and behavioral benefits, right? Benefit parity, but there, we believe, still more work to do. And after Dr. Phillips talks a little bit about what she's seen and hearing from her patients, who may finally find you, we want to hear about that first. We're going to move back to Tim and David to talk about what's left to do in terms of monitoring network adequacy, for example. So Dr. Phillips.
So first and foremost, Yasmin, that was amazing. You are a warrior. I just want to know that. I think all of us were deeply moved by your story, and I almost feel I want to apologize on behalf of the entire mental health field for all of the cracks that occurred on your journey to get help. That should not happen, straight up. And sadly, it happens every single day. I'm pretty sure we're all in good company here. I'm guessing, by show of hands, who in here is a mental health professional? Yeah, exactly. So my guess is that my experience is going to just echo yours. I get 10 to 15 calls a day. I literally had to just hire someone to field these calls because I got so many of women telling me pretty much the exact same story of how they were calling many, many people. They could not find anybody who did this work, or worse, they found somebody who said that they did this work but couldn't do this work. And the distinctions are, of course, it's not just depression after a baby. It's postpartum depression. There are many other nuances that go into that. And if you are not trained, you can actually cause harm, which is what we clearly know. So there's kind of two-pronged problems that occur, I think, but thanks to the wonderful work that Joy and the 2020 Mom program has really done, is that in California, at least, we're screening moms, whereas a decade ago we weren't. So not only were moms highly stigmatized for experiencing postpartum anything, they had no idea how to get help or who to talk to or where to turn. And then we did wonderful things where we created these screening tools, and we required medical professionals to learn how to do that and to ask at least once, hopefully more than once, in that first year after baby. So now OBs are required, or else I think they get punished, I hope they go. They're required to screen moms. Pediatricians are even sometimes asked, and maybe even close to being required, to screen moms at the pediatric appointments, which of course are most of the time you're going to catch these moms, because that 6-week postpartum visit, people are like, I can't sleep, I don't know what day it is, I have no idea what's going on. Maybe they have a little bit more clarity into how they're experiencing their postpartum adjustment concerns after the couple of months in, and they're like, oh, this isn't going away. So I'm hopeful that that is creating a new wave of awareness, which I think it is starting to. The problem, of course, becomes now we're screening everybody, and they're recognizing, oh, I might have a problem, now where do I go next? And of course, everyone's being told the same message. You go to your insurance company, because no one wants to pay hundreds upon hundreds of dollars a month to go see a specialist if they don't have to, and if they have insurance benefits. So they're told, go to your insurance and find a provider. And everyone's supposed to have that work out just great. And it doesn't. It almost never does, because what you see is a list of 20 to 30 people on a spreadsheet of your zip code. Here are some therapists in network, good luck. And then the patient calls every person on that list, maybe gets one person to return a phone call. That's a big problem. And the person that they might actually get on the phone, who can actually take them on their calendar because they're so darn booked up, doesn't have any training in this area. So then we have a huge problem. And they may go to that person and not get optimal treatment, or they go with the next option, which is what these gentlemen talked about, which is they often access out-of-network care. And of course, you're up against a lot of financial burdens there too. Out-of-network deductibles are oftentimes magnitudes higher than regular deductibles. Out-of-network coverage pays anywhere from 20 to, if you're really fancy, 80% of what you're paying that provider. And it's hugely a financial barrier. But there's another major giant red flag reason as to why this is occurring, and that's the problem with the insurance reimbursement situation, as I'm sure a lot of you know. I have a wonderful colleague in the back who actually really helped me identify, because we're in Orange County, which we divide in mentally, not like geographically, into North Orange County and South Orange County, because apparently we can't interact. And we try to take a poll of all of the maternal mental health specialists who actually have training and who take insurance. And we were like, let's put together a fancy brochure so we can give these to doctors, so when they're screening all of these wonderful women who are experiencing a really down point in their lives, they've got someone that they can send the person to who takes their insurance. Do you want to know how many people are in our brochures? About 10. 10 for North Orange County, and what was it, like 10 for South Orange County? Oh, 8. It went down. That's how many we have in a population of millions of people who are trained in this field, who take insurance, or who even offer sliding scale to allow people to access care. And that is because insurance reimbursements are crap. Am I allowed to say crap? Well, I just did. Insurance is not valuing this as a specialty. They're not valuing mental health care as anything. There's no payment parity. We talk about mental health parity, where we get treatment for these conditions, but we're certainly not paid for these types of services. And it's not okay.
Thank you. Thank you, Megan. Yes. And I give you permission to say that word if you feel like you need to. Before we actually turn it over back to Tim or David to respond, I think Stuart, as a behavioral health insurance company, I think we'd love to hear, like, what are your reactions, and talk a little bit about some of the things that Cigna is doing. Cigna, I think, is doing some good work here.
I thought I might get this opportunity sooner rather than later. So Dr. Phillips was here last year, sat right back there in a spot that is forever emblazoned in my memory, and in the Q&A told me that the reason she was no longer taking Cigna insurance is because our rates were not competitive with the other companies that you were accepting. And so my first thought was, okay, keep your friends close and your enemies closer. So we brought her up on this panel. No, I'm just teasing, actually. I'm very glad that you raised that point. We remedied that right away. And I'm thrilled that you're actually on our panel at this point. And I will say, in fairness to Dr. Phillips, what you were asking for was entirely reasonable. You weren't asking for some exorbitant amount, right? It was just to kind of match where the other folks were, which was easy enough for us to do. So I will say it is very concerning to me to hear Stephen's story, and my brain first went to my first kind of defensive thought, well, okay, well, that was how many years ago now? 8, 9 years ago at least. Hopefully, it's, okay, 7. Hopefully we've made some progress since then, but then hearing your story, Yasmin, is a real wake-up call, quite frankly, because here we are in 2020, the year for which this organization is eponymous. I was waiting to use that word. And we're still dealing with the same issues. So the kinds of things that we're doing at this point, first of all, we don't just give people a list of 20 names, 30 names. It's sometimes quite longer than that. We are also more than willing to make those phone calls, send those emails, do what are called customer service searches. And the reason is because, quite frankly, if you're juggling 1 kid or 2 kids in your arms, the last thing you have the time or energy to do is be calling 20 different providers and getting very much the same kinds of answers. The second thing is you found out easily enough is, if there's some rate that's getting in the way of being part of our panel, we want to hear about that, and we want to be able to meet folks where they're at. Our experience is that folks have not been demanding exorbitant amounts. Most people in this room want to participate in our healthcare system, and that means working with insurance so we can offer affordable care to the clients, the employers that we work with. Most people are not asking for $600 an hour for psychotherapy. So, all reasonable offers, I think we're happy to entertain. On our website, and this is been true for a while, but you can look to see who actually specializes, who has some comfort and expertise with this particular field. And it is concerning to me to hear that the numbers are so low when you looked at how many folks were actually working with insurance. So that is a call to action for us. And I can say more, but I'm getting the nod, so I'm going to...
That means, yes, we agree. And again, just one more shout out, if we could. Cigna helped the field identify that there was a need for a certification in perinatal mental health, because insurers can't check, okay, this person said that they were trained, but, do we say that they're an expert just because they received a little bit of training? And again, just want to thank Postpartum Support International, Wendy Davis, executive directors in the room, for developing this certification that Megan has received and others. And Cigna is now reimbursing those trained providers at higher rates. We want to see more insurers do the same.
And Joy, kind of one other thing worth the applause. One other thing to add is if folks cannot find care within network, we cover that care at an in-network rate, even if folks have to go out of network. So people are not penalized for a network adequacy issue with an insurance company, at least for us, and hopefully that's true elsewhere. Thank you.
A policy point on that front is that California actually has a state law that requires, if there's a network adequacy issue, that insurers reimburse at in-network levels in terms of patient copays, and that a letter of agreement be put in place with that non-par provider. And Cigna does a really good job at addressing that. We're going to turn it over to our policy experts for response.
Yeah, just to follow up on that point, the single case agreements, this can actually be a problem if you're trying to negotiate a single case agreement that's very low, and the provider won't accept it. So we're actually looking at strengthening some of these requirements, because we actually think if the insurer doesn't have in-network providers who meet the patient's needs, then there shouldn't be any flexibility in covering out-of-network care that's appropriate. And so where state and federal laws don't ensure that as an actionable right, that we should make that an actionable right. But I guess I would put, and I think insurers hopefully are increasingly stepping up to the plate. But I guess I would like to challenge insurers to make sure that they have adequate networks for every type of provider that their members need. Now, obviously, there are other issues in terms of workforce shortages, but where there are providers in Orange County, and there's a lack of in-network providers that meet their enrollees' needs, they need to be increasing the reimbursement rates until they get those people in their networks. Because if they don't do that, then we're in this kind of bizarre situation where there's kind of this back and forth. Basically, it's finger pointing, and you don't get the in-network coverage that people need. So I would like to, put it on the insurers that they actually have to raise network rates until they get an adequate network, which is what you see in things like oncology and other areas, that if they don't have enough oncologists, they will raise rates until they get enough oncologists. So I think that's a critical step that needs to happen.
But before we pass the mic over, how does this work practically speaking? Is it that an insurer would say, we're going to pay all perinatal mental health specialists or all child, OCD specialists? Like, do we advertise the rates on a website? Like, what's the practical way to implement this step? Because I think it's important. Or do we say, attention all therapists, start calling Cigna and Aetna and everyone now and, ask for such and such amounts? Like, how practically do we implement that step?
If that's for me, yeah. So a few things. First of all, I think for us at Cigna at this point, we have an any willing provider policy. That's new. So it used to be we looked at different markets, and a lot of these rates are market specific. So what you might be paid in Boston is going to be different from what you're paid in Topeka, and it's based on partly supply and demand. It's based on cost of doing business, cost of living, a whole host of factors that are market specific. So hard to have a broad umbrella, but certainly we have a general sense of what people are making out in the community, and how close we can get to those rates. The other thing I'll also say is, look, I think everybody deserves a raise. And it's very reasonable to talk to the insurance companies you're working with on a regular basis, once every year, once every 2 years, and say, look, these were the rates that I paid last year, and I need to pay my office staff a little bit more, and my rent has gone up, and by the way, I'm a better therapist even than I was 2 years ago, so let's talk rates again. very reasonable conversation, and people forget that they can have that conversation, and I think that's partly because we look at insurers, and I understand the reasons why for this, but we look at insurers as these vast behemoth bureaucracies, and what they say goes, so it's either take it or leave it. And you can come to here and stand up in that corner and make the point, or you can just give us a call, and they both work very well. So please call us for any questions about rates. Sure.
Yeah, so I think some great points brought by Stuart and David. And I think that, when it comes to networks and the availability of providers and reimbursement rates, the parity law actually does apply to that stuff. And I think that, Stuart just mentioned something that's very relevant, supply and demand. Right now in the United States of America, every day 300 people die of a drug overdose or a suicide. And demand for behavioral health services has never been higher. And yes, there are shortages of providers. With every other kind of medical specialty, when you have a scarcity of providers and an intense demand, rates go up. That's what supply and demand is all about. And I don't think, it sounds like Cigna is responding in a way that is appropriate, but I don't think we're seeing that across the spectrum of payers. I think we're seeing that the rates are the rates, and the rates are going to be what the rates are going to be, because that's what we've paid and that's what we're going to pay. And I think that a lot of our members do find it's a take it or leave it situation, not necessarily with Cigna, but with many payers. And I think that, with other medical conditions, if you had someone seeking treatment for, a heart attack or cancer or something like that, and you said, well, we only have 3 in-network cardiologists and they're all booked up, I'm sorry. Or that they were only paying cardiologists $140 an hour in reimbursement, and a cardiologist could get $300 an hour, out of pocket. You're not going to find too many cardiologists taking that, and you don't see that at all. The day that an insurer would say, well, that's the number of cardiologists we have in our network, I'm sorry. You're just going to have to wait for that heart attack. You're going to have to get that treated somewhere else. That insurer would be on 60 Minutes the following week, and that's something that we hadn't seen in the behavioral health side of things, which we are seeing now. I do think we are seeing that change, that shift, that emphasis and that pressure being put on by the media, by the public. And I do think the insurance industry, I do think they do want to get there. I think, as Stuart just mentioned, they are willing to. So I think that I would recommend that if you are experiencing rates that are, what you think are abysmally low, have that conversation, have that negotiation. Part of supply and demand is to make sure that those that are the supply, make sure that it's known to those that are paying that, look, there's a huge demand for these services and I can't meet it, and I can't survive in network given the rates that you're giving, and then maybe they will negotiate. But the parity law does require that the way insurers design and maintain their networks has to be comparable to what they do on the medical side. And the same thing when it comes to setting those reimbursement rates. So while the law doesn't say that the reimbursement rates have to be exactly the same, it says that those factors like supply and demand, market, scarcity, have to be comparable in terms of how they apply them. So I think that we're looking at a time where rates are still lower for behavioral health providers than they are for other medical providers, yet you have such a huge unmet need and demand, and you have people dying by the hundreds every day. So that's all I'd add.
Can I offer just a quick negotiating advice
Please.
for folks? When you call your insurer, one of the things we're very interested in is, are you already, if you're in our network already, right, where you think you've signed on for life to the rates you got back in 1972, it's helpful if you can say, look, I am taking care of 16 of your patients, right? You should say that. You should tell us how many patients you're taking care of, because that tells us that we have relationships that we want to preserve with those patients. We don't want to see those patients have to go elsewhere if they're getting good care from you. And if you're not in our network yet, you can tell your insurer, whether it's us or someone else, by the way, I have 3 or 5 single case agreements already with on behalf of your patients, if it's Cigna, right? And that tells us that, okay, this, we can do the math, right? Just like you can. We'd rather have you in our network and work something out that's going to work for many more patients than the 3 or the 5 that you have single case agreements with for out-of-network care. So use those numbers when you come talk to us.
Helpful.
Sorry.
Thank you.
Yep.
Gentlemen, I have a question for you. This concept of single case agreements, again, the network's not adequate. Patients might call 7 people on a list and then not know what to do. They go out of network. Does it seem like there's a policy opportunity to disclose the right to request a single case agreement, national policy opportunity there to patients, and also to have insurers issue denial letters? What happened with Yasmin's situation is we knew that we could request a single case agreement. And so we helped navigate that system with her insurance company. But guess what? No written denial letter. So we have nothing to appeal. When there's no written denial letter and you can't appeal, then it's sort of this phantom no, right? A phantom no with no documentation that we can't act upon. Your response, is that an opportunity?
Yeah, I think the rules across the country vary, but no, I think that people should know what their rights are and should be able to assert those rights without going through, a Kafka-esque system, where they get lost and can never get out. So I think that is critical. And I'm sorry, the second part of your question was
documenting those for single case agreements.
Denial. If you're not getting a denial letter and you've been denied services, that's against the law across the country. And we would hope that regulators would be policing that pretty aggressively. I see a lot of instances, frankly, where we have people complaining that that's not happening. Granted, they're coming to us because they're having problems. But no, that is, and I think some insurers may frankly use that sometimes as a strategy, because if you don't have a denial letter, it's much more difficult. So they're good actors, and they're perhaps a bad actor or two. So it's really important that regulators be overseeing these laws, because if you're denied services that you're requesting, you should be getting a denial letter.
Great.
Yeah, and just one thing I would add too about denials. A lot of times, unfortunately, and I think many of you in this room might be familiar with this, particularly if you deal with the inpatient side, is if you're seeking, let's say, coverage for an inpatient stay, the insurance company will often give you the option, do you want to, I can deny this and you can try to appeal this, or do you just want to take an approval of intensive outpatient treatment or some lower level of care? So you end up saying, well, I want my client or patient to get care, so yes, I'll get approved for that lower level of care. So you're denied that inpatient benefit, but it never shows up as a denial because you're accepting the outpatient coverage because you want your patient to get something. So a lot of times for there to be an actual denial, the provider is going to have to say, no, I'm not going to accept any level of treatment for my patient right now, and I'm going to appeal this. And that's something that can be challenging. It's a bit of a quirk and a bug in the system, but it is sometimes a problem.
Yeah, really good point. I wanted to bring up one other topic, and then we're going to ask each of you to leave us with any parting remarks that you might have. Two topics. Workforce shortages. So I'm curious, our policy folks, and also Dr. Lustig, if you're familiar with any efforts to recruit certified peers. So we have a panel tomorrow on certified peer specialists, but we know all 49 states, California is the one exception that doesn't have a certification process in place yet. That should change soon. We know Medicaid is reimbursing for services around use of certified peer specialists. Any thoughts on recruiting both certified peer specialists to augment shortages? And then any other comments, I guess, around shortages and telemedicine, telepsychiatry? What kinds of trends are you seeing in this space?
Well, yeah, I think so. A number of insurers have been stepping up to cover peer support because they see the evidence that shows that it's so effective. The people that get peer support, in addition to support in treatment from whether it's a psychiatrist, psychologist, social worker, licensed counselor, if you get that peer support, the outcomes in terms of rehospitalizations, interface with the criminal justice system, all kinds of things are much better with that peer support. Peer support works. It's something, there's a lot of evidence behind it, and I think that's something that I do think that payers are starting to recognize that and are covering it, and I think that's important. And I think that when it comes to provider shortages, as you mentioned, there are some ways that you can, telepsychiatry and other forms of telemedicine are a great way. The psychiatric collaborative care model that you mentioned earlier, that's a way where you can get a more efficient and coordinated delivery of care and has much greater, has great efficacy and good return on investment. So I think there are lots of innovative ways to dealing with provider shortages, but also, when you do have provider shortages, you have to make sure that there's as much of incentive as possible for them to join a network.
Do you think there's policy levers there to perhaps require peers be added to a provider network, for example?
Yeah, I think the organization Mental Health America actually has model legislation written up that would do some of that. So I think that, so if you're looking for policy levers, that's an organization, Mental Health America, that I think does have some solutions when it comes to this.
Great. They're a good partner on the peer front with 2020 Mom as well, so thank you for that. Did you have something you wanted to add?
Yeah, I think it's important to look at the data for peer support. And it's been about 6 months, honestly, since I looked at it. But when I did, I found more in the space of oncology, for example, or other parts of medical care than I did for behavioral health. That said, we are moving at Cigna forward in looking at it for substance use treatment. We've been undertaking a major effort to combat the opiate epidemic. But I think particularly for our purposes here, as I've heard just about heart-wrenching cases of inadequate care, let's make sure that the peer support helps. And maybe it does, and I haven't seen the latest data, but that would be my one caveat for this group.
We have great research, and you'll hear about it tomorrow.
Okay, good.
Good.
Excellent.
One final question before we hear from each of you again and open it up to questions. There's this concept of insurance parity with behavioral health and medical contracts. So you all may know and have an insurance policy yourself. You're written, and we can pick on Cigna, I think, a bit here. Cigna Healthcare of California is my medical insurance policy. But my behavioral health insurance comes from Cigna Behavioral Health of California, a separate company. We know there's other mental health carve-outs, right, insurers. And this fragmentation, we heard the cardiology example earlier from you, Tim, which I think was a great one, but there isn't a Cigna Heart Health of California company. And so I'd like to just hear from folks on the panel briefly about what these are barriers, I think, that both providers, so hospital, for example, in Stephen's case, maybe there would be a hospital that would want to provide behavioral health treatment, but they only have a medical contract, so they're not providing behavioral health care. And they haven't thought about, well, I need to go to a separate company and serve this person to give them behavioral health care in a hospital setting, for example. And just patients being not well, right, and depressed or anxious, having one more phone number to call and system to navigate, or an OBGYN needing to call versus talking to the dermatologist down the hallway who's on the same panel. Those kinds of things seem to be difficult for patients and providers to navigate. Anyone have a response on that? And Tim and David, please share your thoughts.
Well, I do think it sends a terrible message when you turn over your insurance card and the mental health and substance use benefits are at a different number. It really reinforces that it's separate and probably unequal. And that's not a good message. And the Federal Parity Act doesn't make any distinction between whether it's one company or two companies that are managing the different benefits. And so we need to de-silo our healthcare system, and that includes our insurance system. And so hopefully more insurers will get rid of this bifurcation. And I really don't think we should accept it. I don't think there's evidence that it causes major problems, as you suggest, and we should look at ways of at least discouraging it, if not insisting that it's all housed together.
Great.
And let's not forget the fun experience of mental health carve-outs, where you have a thing on your card that says this is your insurance benefit, and then you go and call that person, and they're not a network, but it says you're a network, and what's going on? It's because it got carved out to some weird random company like Beacon or Magellan or something else, and you're like, wait, what's this about? Yeah. So that just complicates things, and it's not straightforward for the patient. So all under one roof model in an effective way is a good strategy.
Dr. Lustig, don't feel like you need to respond, but feel free to if you'd like to. Tim.
Yeah, I think that when you have those carve-outs, as David said, the law says it doesn't matter if you use a separate company, you have to follow the law still. And I think what I've found in working with regulators and working with the plans that do use those vendors, you have two separate companies. You got one company doing the behavioral health benefits, another company doing the medical benefits. I mean, and if they're not coordinating very closely, the only way they're in compliance with the law is through blind luck. So I think that challenge, and I've worked with insurers that have those behavioral health managed care organizations, and it's really hard to coordinate. So I think that when you have that bifurcation, you have those carve-outs, especially when they're separate companies owned by completely different entities, it makes it challenging to be in compliance with the law.
Go ahead.
Yeah, I have a comment about a related issue as opposed to which company you're with. It's just the going to an in-network facility, to an in-network ER, and then finding yourself in an out-of-network, at their out-of-network inpatient unit for behavioral health, which, there's which could be an issue for folks taking care of our patient population that we're talking about, because that happens probably more commonly than we would like. And how do we address that issue?
No, that's helpful, thank you. In the interest of time, I want to make sure we have time for questions. Is there anything burning, so we're not going to go down the line, but anything burning that you didn't get to address that you feel like you need to, panelists, before we open up for questions? Okay, Yasmin.
In regards to the insurance and people not accepting my insurance, I called Alexis's foundation, and I knew that I needed proper help, and that this was before we met. I got denied in that and got told an astronomical number that I would have to pay, and we're a one-income family. And also when you're dealing with any type of mental illness, but I obviously know more about maternal mental health, the last thing you want to be doing is calling multiple numbers and getting voicemails. I'm full, I'm sorry, I can't accept you. I can accept you, but it's going to be about $200 an hour. Or, why don't you just try in-network, keep, calling in-network, which I did. And it was extraordinarily frustrating to the point where I almost gave up, because you can only get no so often, and when you're not only dealing with postpartum depression, but then you're having to advocate for yourself, it's exhausting. It's exhausting. I've said to my husband, I don't even know how I'm still here, because I just was hit with so many blocks that I just kept fighting and fighting and fighting. And that's why I'm so passionate about this, because I don't believe any woman should have to go through this, and spouses should have to see their wives suffer. And my husband will attest, he doesn't know what to do. He doesn't know he hasn't dealt with having babies and growing babies. He's the biggest support, but it's just not right. So something needs to get done, because we can't keep losing women because of either lack of insurance or lack of education for medical providers. So that's my 2 cents.
Thank you. All right, it's your turn. We're collecting cards, and we also are reading from the app. Very good.
Hi. So one question or 2 questions from online. What are your suggestions for figuring out what network adequacy looks like for various insurance companies in different states? We tried calling companies a number of years ago and either received no callback or they were directed to the lawyers.
Well, I think just documenting, those types of, you can test, if you're an advocacy group, you can go through and test in-network, in-network directories to see, what they say is available versus who actually is available, and whether they're actually still in network, whether they're accepting new patients. And bringing light to that type of thing can be very helpful in pushing regulators where there already are laws on the books, regarding network adequacy and timely access, and in other states that may need stronger laws, pushing for those stronger laws. So I think that's critical, is testing of network directories to make sure that they're accurate and that they're also adequate.
Yeah, I would just add, from an insurer's perspective, there is a a great deal of sophistication that goes into assessing our network, and this is true for all companies, I think. There are a number of metrics that we look at, ranging from how many providers per population in a specific area, how many providers within easy driving distance, or within time it takes to drive, or distance. So those are the kinds of things we look at to do our best to ensure network adequacy. And as you've said earlier, it is a huge challenge for mental health, but those are the kinds of things we look at.
I'll add to that point as well. Coming from a compliance department at an insurance company, California has some of the most progressive laws around network adequacy and provider directory accuracy in the nation. So a California model is something to look at from a policy perspective. Also, you have state regulators. We've heard alluded to the fact that there are regulators that oversee insurers, and that person who had trouble getting a response, you should be calling the state regulator to say, I need help with this assessment. I will tell you there's a gap in California that for behavioral health requirements, insurers are not yet required to talk about subspecialty, so it's only licensure. So how many LCSWs, how many psychiatrists, how many such and such. It's not how many, not yet, right? Perinatal mental health providers, it's not how many child therapists that specialize in OCD, for example. That's a significant gap, and until that's measured, we're going to continue to have problems. More questions?
Yeah, I'm going to hand this to Wendy because she's right behind me with her card.
That's what you have to do to get the mic, is stand right here. Thank you so much. I just want to thank all of you. Your interest and your compassion is obvious and inspiring. I wanted to say that this is one of the reasons that there's so much we can't do in this room, in this world, but we can really create a bridge, a better bridge. So that's one of the reasons PSI has a national perinatal mental health provider directory. It's online. I did a quick search. Megan, there's 190 California perinatal mental health specialists on the online directory. So just go psidirectory.com and you'll find that. And that's why, because as you all said, nobody should work this hard, including insurance companies. Just a little, 75 of them provide online services and 25 of them are Cigna providers. The Maternal Mental Health Task Force also has an amazing provider directory. So you have to let the social support organizations help build that bridge, and we don't want anyone to have to search that hard.
Thank you, Wendy. And one thing we'll add, and this is another lever for all of us in other states, is we can take those directories, and we did this in California. We took the list of all trained providers, not just with the new certification, but any trained provider, and we gave it to the regulator. And they're interested in starting to look at how many of these providers are in each of our insurance networks in the state of California. So these are things that 2020 Mom can assist other states in doing as well. Great.
The insurance companies are also using psidirectory.com when they're looking for providers. So thank you.
Yep. Thank you, Wendy, and thank you to Maternal Mental Health Now as well for maintaining those lists. Hopefully someday we won't need them, right? Just like we don't have separate lists for cardiologists, but we need you desperately now. Thank you, Wendy.
Here's a question concerning the shortage of professionals entering the mental health field. My experience, not mine, but the person who wrote this, as a nonprofit training agency is that insurance companies do not reimburse for licensed MFT interns who are certificate trained in postpartum depression. Why is this any different than seeing a medical intern or nurse practitioner?
So I'm not sure if I can speak exactly to how it works on the medical side of Cigna, but we do need a licensed clinician to bill under. So they may be working in tandem perhaps with someone who is licensed. That's not uncommon for psychologists at various stages of training. I'm not sure how it works for medical interns, but it's a good question.
Yeah, I don't know the specifics of that particular issue, but I will say that the pipeline of providers' current reimbursement rates affects that. because you have people looking to go into the field and they can see the landscape and they can say, I'm not going to be able to make ends meet. I'm not going to be able to have, I'm going to go into some other specialty that's more remunerative. And so that's also critical for getting the pipeline going in, is getting current reimbursement rates higher.
Excellent. Well, we are out of time. Keep the questions coming in the app, though, and we can encourage our speakers or panelists today to help us answer those in the app. I want to thank this esteemed panel. I think it was a groundbreaking discussion. This kind of discussion I don't think has happened much before. So we thank our experts and our mom and our patient and our mom and our provider. Thank you so much, and Dr. Lustig as well. Help me give them a round of applause.